Good morning and welcome to PCLA Signature Educational Conference, Life Beyond the Basics 2023. This year, we are proud to announce that our talented presenters are none other than PCLA's entire medical advisory board. My name is Prebiotics. I'm president of Parkinson's Community Los Angeles. To all of you who have attended our events in the past and to all of you new to PCLA, welcome. We're here to connect, support, and inspire. PCLA is a nonprofit and we are different. Our mission is to make lives better today. We do this by addressing the neglected aspects of a life with Parkinson's. By identifying and naming these nuanced needs, PCLA empowers individuals and families to live better and reach new heights. PD is a neurological disease that affects not just the individual, but the entire family. A holistic and comprehensive approach to managing can make life better. This year, we wanted to present something different. It's time for a change. It's time for innovative and leading edge strategies that make your lives better right now. Today, we're going beyond the basics, as the title implies. There's a wealth of content on the fundamentals of Parkinson's available online. Today, we're digging deeper, way deeper. We like to think that this is what sets PCLA apart and above. The collective knowledge of our panelists provides a rare opportunity to delve deeper into matters that affect your quality of life. To that end, today we're tackling 7 hot topics that affect the lives of families living with Parkinson's. With each topic, we've asked our presenters to provide you with 3 actionable strategies that you can incorporate into your daily lives to make things better. Today is for you, the person living with Parkinson's, you, the care partner, and you, the family member or friend. PCLA is different. I know today will be an affirmation of that, but we need your help to continue. We count on support from people just like you, so please make your year-end tax-deductible donation today. As we learn together and enjoy these presentations, you will see an occasional clickable link in the chat that will take you to our donation page. Please help us continue our mission. This year, we're also searching for sustaining donors who'd like to partner with us on a more significant level. So if you'd like to help us chart our future and learn more about that life-changing opportunity, please reach out to Vivian@pcla.org. This year, we're celebrating 7 years of serving the community, and our reach has grown to now include both a national and international audience. So no matter where you live, if you value PCLA and want to see us continue, please donate. Now, on to our event. I want to extend our gratitude to our sponsors, Acadia and Medtronic, for making today possible. And of course, thank you to all of our individual donors from all over the world who have made today and tomorrow possible. Here's today's schedule. As promised, we've got 7 hot topics for you, as well as a movement break from Ping Pong for Good. Our first topic is hot. It's the gut microbiome and Parkinson's. Dr. Wael El-Nashef is a gastroenterologist specializing in the GI manifestations of Parkinson's disease. His clinical interests include the gastrointestinal complications of neurodegenerative disorders such as Parkinson's, esophageal and gastrointestinal motility disorders. It is a privilege to have you here today, Wael. Thank you so much for joining us.
Thank you for having me. So I titled this talk, Strangely Familiar, Parkinson's Disease and the Microbiome. And I say this because, when I meet patients, many of them are familiar with this concept of the microbiome and its potential role in Parkinson's. And it seems very intuitive to the general public. But for me, it's such a complicated question that, it always surprises me how big it is in our, community to know about this, but there's still so much unknown as well. For some reason, it seems intuitive and that we can wrap our minds around it, but there's still really a lot we don't understand. So as mentioned, I'm a gastroenterologist. I'm not a neurologist. I'm also a basic scientist, but in my research, I studied the nervous system of the intestine, and I was introduced to this idea of Parkinson's and GI issues through some of my research colleagues who encouraged me to see patients because no one else really knew what to do with these sorts of problems. And so what I found and what others have found, Parkinson's can affect the GI tract at every segment. You can get problems with the esophagus, the food tube, stomach can move slowly, gastroparesis, Your small intestine can move slowly, and that can cause small intestinal bacterial overgrowth. So you can get constipated if your colon moving slowly. You have difficulty passing stool because of uncoordinated muscles in your rectum and anus. And what is Parkinson's? And so this might be a little bit technical, but essentially it's damage to certain types of neurons. And we mostly focus, at least originally focused, on the brain. And so you can see that there's this black material here called the substantia nigra. That's where the dopamine neurons are. And in Parkinson's, you lose that. Those neurons die. A lot of people are aware also that other symptoms other than the motor symptoms that are commonly associated with Parkinson's, like the tremor, you can get things like constipation many, many years before. And it turns out that the intestinal system has a huge nervous system as well. It has as many nerve cells as the spinal cord. And these potentially could be affected directly by Parkinson's disease. And that that in many patients, the GI symptoms precede the tremor and the other motor symptoms. People have thought that maybe Parkinson's starts in the gut. And in fact, the gut and the brain are connected, like literally connected through different pathways of nerves. This brings me to the idea of the gut microbiome. So just in terms of background, we have bacteria in our gut normally. This is, a healthy thing. And we've co-evolved with these bacteria for like millennia, and don't live rent-free. Give them a safe place to live, but they benefit us. And because they produce things called metabolites, and they also help us produce vitamins, etc. And that helps us with our normal body functions. This is normally, things are going well. This is a symbiotic relationship, a win-win, quid pro quo. When this goes wrong, we call it dysbiosis. And this can often cause symptoms and potentially even contribute to or cause diseases. And that's where a lot of research has been. And it's not just GI issues. It can, there's been research into autoimmune diseases, of course, Parkinson's, etc. We do know for sure that people with Parkinson's have different bacteria in their gut and different balances and different mixes of bacteria than when you compare them to people without Parkinson's. This dysbiosis cause Parkinson's disease. And so there are some theories that in the setting of chronic inflammation from whatever cause, maybe environmental triggers, etc., this will alter the microbiome. And then through the inflammation, the gut is more permeable or leaky and allows these bad actors to cross the barrier of the intestine and lead to the accumulation of alpha-synuclein. Other question is, maybe it's the reverse. Maybe this dysbiosis is just a side effect of having Parkinson's because your gut's moving slowly and you just, this changes the bacterial makeup. And so this is not really the cause, but a symptom of Parkinson's. So, this has led to a flurry of research studies. Of course, we always start in animals. And there have been some super interesting studies that were done in mice, for example. And one of them was done in a lab in Caltech, in the lab of Dr. Mazmanian. And it was extremely intriguing. And I think it led to a lot of interest in this field. And they showed that you could actually do fecal transplants, and you could treat essentially mice with Parkinson's disease. And so this gave a lot of hope. The issue is that mice and humans, without sounding too obvious, we're very different. And especially when it comes to the microbiome, there are some really important differences that are hard to translate. And so I spent a lot of time looking at the basic science or animal studies that have been done. But where the rubber really hits the road is when it comes to human studies. And now we're starting to enter the realm where we're testing some of these concepts in humans. And so I think that's where I'd like to focus today. So we'll start by the different ways of adjusting the microbiome. And you can start by replacing the bacteria with fecal microbial transplant. There's a lot of different ways to do this, but essentially you get a donor, someone who gives a sample of their poop, essentially, and you ingest it one way or another. It can be given through an upper endoscopy, a colonoscopy, an enema, and more recently, and I think it's becoming more common, it's given as capsules. Like it's put into capsules and you can just swallow them. It doesn't require procedure. And the idea is that you're replacing a bad microbiome with a good one. So what do people use FMT, or fecal microbial transplant, for? So I believe the only FDA-approved indication is for a certain type of infection in the colon called C. diff. And this is really well established and it works pretty well. There's growing movements to look at it in different forms of inflammatory bowel disease. But if you look online, it's been used in every type of condition under the sun with mixed results, and the studies are small. And, I think there's a lot of interest, but we'll see where that goes. When it comes to Parkinson's disease, there's different levels of quality when we look at studies related to FMT. And, there's earlier studies where they just took all comers, gave them FMT, and saw how they did. And those are okay when you're first exploring an issue. But what you really want is an unbiased study. And that means that the study is randomized. You have people who get placebos, like, they get dummy pills or sugar pills, etc. And you don't know who's getting what until the end. And so this is a way to get good quality evidence. And also, if the study is too small with too few patients, it can also limit the quality of the study. There was recently a study that came out that was randomized, controlled, and blinded. So this is, a good study in terms of its design. Wanted to go through it really quickly to see what is the state of the evidence these days. But it was actually a pretty small study. The total of 12 patients, where 8 of them got the FMT, and these are all Parkinson's patients, I should say. 8 of them got FMT, 4 of them just got placebo, but nobody really knew what they were getting until the end of the study. The issue was that the placebo group wasn't exactly comparable to the to the FMT group. They had more advanced Parkinson's, so that might make it difficult to compare. But that's the issue when you sometimes have a smaller study. So the FMT was given as oral capsules, and they were given twice a week for 12 weeks. And when you get a dose of this, you have to take 6 large capsules. And they took a mixture of 3 different donors to get a nice mix of bacteria. The first things first, that it was safe, like FMT was safe, there was no serious side effects, and it was generally well tolerated. Because if it's not safe, it's all cards off the table, we're not gonna use this. So that's good news. They checked the microbiome of these patients, and they saw that indeed, the patients who got FMT, their microbiome changed in a good way. It was more diverse, and they had the healthier bacteria in their gut. They had a movement disorder specialist measure their Parkinson's disease activity before and after the study. They didn't see objective signs of improvement. They would ask the patients, did they feel better? And this is with the patients who didn't know whether or not they were getting FMT. The patients who got FMT subjectively felt that their Parkinson's was better. Also, they appeared to have improved GI motility, like their constipation improved and their GI tract moved faster. So there's some signs there that it is helpful, but it's super early. This is a small study, but there's a good signal there. So it's interesting. Fecal microbial transplant is interesting, but it's too early for me to recommend. And in this example here is a little bit tongue-in-cheek, but there's someone who is doing FMT do-it-yourself at home, taking samples from his mother, and then he ended up reporting that he got her menopause symptoms. And the point here is that, if the FMT might give you the good stuff from the bacteria, but you don't know what else it's going to give you. And like maybe menopause symptoms in this rare example, but also things like infections. There's people who have had obesity if they got stool from an obese donor. We don't know exactly how this is going to play out. So it's still really early, and I wouldn't jump to it. And there's other questions like, how long does it last for? Do you have to get repeated treatments? Should you get antibiotics to clear out your gut bacteria first, et cetera, et cetera? It's still pretty early. So we talked about replacing, but what if you took antibiotics to remove bacteria? Some studies to show that H. pylori, which is an infection of the stomach, is more common in Parkinson's patients, and Parkinson's patients who have H. pylori tend to have worse motor symptoms. There's mixed results, though. What happens if you treat the H. pylori infection? Some studies say that Parkinson's gets better, some say no. So I think you should treat H. pylori just because it can cause other problems, but I don't think this is going to cure Parkinson's. Then there's small intestinal bacterial overgrowth, which I alluded to earlier, also known as SIBO. It's not an infection per se, it's just that you have too much of the normal bacteria that's normally in your gut. And this is usually due because the small intestine isn't flushing out the bacteria periodically as it should. So the bacteria get to hang out and reproduce more. So you can treat SIBO with antibiotics. And there's been some studies to suggest that motor symptoms might get better if you treat the SIBO. However, like about half of the patients get recurrence within 6 months. And I bet all of them recur within a year. So it's not a long-term durable solution. In my personal experience, I noticed that the SIBO tends to go away if you treat the underlying dysmotility. If you speed up the intestine, then this usually treats the SIBO in a more fundamental way. So probiotics, this is the idea that you're adding good bacteria to your gut. There's been a lot of studies out there to this regard. So what I rely on in these situations when there's a lot of studies is something called a meta-analysis, whereas someone takes together all the studies that have been done and using statistics comes out with a overall conclusion of what's the benefit of the intervention. And so in this meta-analysis, which is relatively recent, they concluded there's insufficient evidence to support probiotics and Parkinson's. So, for me, I've never been gung-ho about probiotics because, first of all the studies are very different about which bacterial strains they use, which pills, how much, etc. And even if you decide on what you wanted to use, most of them, almost virtually all of the probiotics you would buy are not FDA regulated, meaning we don't know exactly what's in them. My take is it probably won't hurt to take them, but I personally wouldn't spend my money on it. Instead, I would just try to eat foods that naturally have probiotics in them. Things like yogurt, kefir, kimchi, sauerkraut, etc. Lastly, prebiotics. And this is the idea that you're feeding the good bacteria that's already in your gut and promoting the good bacteria by giving them good substrate. So there's some early evidence that prebiotics can improve Parkinson's, but there's like very few studies about this. But the take-home message is that prebiotics are essentially just foods that are good for you. They're, like plant-derived foods, high fiber, etc. And I would just recommend anyone, Parkinson's or not, have a diet rich in prebiotic foods. And I can send a link in the comments later with a good list of foods that are included in them. So my takeaways are that microbiome may or may not play a role in Parkinson's. This has captured a lot of our imaginations. I think it's very interesting. I'm a skeptic, not like in a sense where I'm saying it's not true, but I just need to be convinced as a scientist. And I'm not quite there yet, but I'm open to it. There are various treatments that you can target the microbiome, whether you're replacing, removing, adding, or promoting different bacteria. But right now it's not fully proven whether those will fix your Parkinson's, so to speak. Regardless, don't delay treating your GI symptoms because you're pinning all your hopes on the microbiome. There's things we can do to help GI symptoms, right away. So you don't have to wait for like FMT to be approved for Parkinson's, which might be years from now. And just in general, make sure your colon cancer screening is up to date. I can't tell you how many times I meet people who've never had a colonoscopy. Just because you have Parkinson's doesn't make you immune to the other stuff, unfortunately. So if you're due, get your colonoscopy. Thank you very much.
Thank you so much, Wael. That's awesome. So we have a couple of questions here. First up, we have a question from Pat Young. I have been experiencing a total intestinal shutdown for the past 2 months. My primary care doctor advises getting more exercise, and I'm taking magnesium citrate 2 to 3 times a week. I am only now realizing it is Parkinson's related. What should I do to get back to normal?
Okay, so I mean, I can't give you like direct medical advice, I would say, but in general, I think you need to be on some sort of a bowel regimen, and it would probably include, attacking the symptoms you have in 2 different ways. So you want to have something that will help speed up contractions, and something like Miralax, which will bring in more fluid into the GI tract, and that will be a good place to start. If you are having symptoms like severe abdominal pain, if you can't pass any like stool or no gas, if you can't tolerate oral food or water, you need to go to the ER to make sure you don't have a blockage. But essentially, meeting with a GI doctor to help you get on a good regimen is your first step. If you can find a motility specialist, or also known as a neurogastroenterologist, they can be a good place to start too, because they'll have expertise in the sort of problems you're having. And I'll say, a lot of people ask, like, where are there motility specialists? I would say first start with like academic institutions in your area. Most of those places will have a motility specialist.
Great. Do you recommend any strategy after taking a course of antibiotics?
That's a good question. I would say in terms of evidence-proven things, it's hard to say. I often will recommend patients try to eat more yogurt during those times, because it wouldn't hurt. And there's some thoughts that it could prevent side effects from antibiotics, such as like C. diff infection. But generally, I would try, my main advice is avoid antibiotics unless you absolutely need to take them. That would be my first line of advice.
From Diane, I'm doing Metamucil Miralax to improve motility, constipation, but I'm uncomfortable with the routine. Do you have any recommendations?
So, yeah, I mean, I think both of those medications are super safe, and I recommend them all the time to patients. The one thing I would say about Metamucil or psyllium is that it's a fiber. It's natural. It's great. However, if you're coming into treatment severely constipated and you're adding in a large amount of Metamucil, it's going to really set off a lot of bloating. So I would usually say try to get a better handle on the constipation first, and then very gradually introduce the Metamucil. Like, I'm talking like 1 teaspoon a day, and then do that for a week or so, and then increase it gradually. Because I see too many people, they're super constipated and they take like 4 tablespoons, and then it's not pleasant.
Okay, what do you recommend for pre and probiotics?
So in terms of prebiotics, these are foods just like that are like you would have in your diet, like oats, like natural grains. Most fruits and vegetables are good sources. And I will put there's a good list from actually it's Children's Hospital Philadelphia had a really good list, and I'll put it in the chat after we're done here. So it has a huge list of things that they recommend.
When you experience gastro problems, does it make sense to begin seeing a nutritionist?
Yeah, I think many of my patients that I see, I recommend that they see a GI dietitian. I think it's important to try to find someone who has familiarity with Parkinson's, though, because there's some issues that are, that many people aren't aware of, specifically like timing of carbidopa, levodopa around meals, etc. And some of the issues related to weight loss and like loss of appetite due to loss of sense of smell, etc. If you can find a GI dietitian with familiarity in those, that's great. And because, for me, I usually focus more on the medical side of treatment, or like testing, etc. But the dietitians can spend like an hour with you about what to eat. I feel like it's we often get clumped together, but the dietary issues are like a whole different area.
Can you just briefly go over the distinction between a nutritionist and a dietitian for the?
So, the truth is, I believe nutritionist is an older term, and the people I work with describe themselves as dietitians. I'm not exactly sure. They're probably pretty much synonymous, but that's the new nomenclature.
Would a product like Linzess for IBS-C be a good option versus OTC or probiotic?
So Linzess works by increasing secretion of fluid from your intestine into your colon. And in like IBS, for example, it works great. This is totally anecdotal from my experience, that Parkinson's patients either have no response to Linzess or they have an extreme response to it. And I often try to avoid it, because either they get no benefit, nothing happens, or they have severe diarrhea to the point where they get like lightheaded and might pass out or something, especially if they have like issues with low blood pressure related to Parkinson's. And so I usually try to go with something that increases the contractions of the intestinal tract. Over the counter are things like Senna or Bisacodyl, but there's stronger prescription strength medications called, like, for example, Motegrity. And that's also a really great medication that I've had good experience with in Parkinson's patients.
I'm going to ask, I take psyllium husk daily plus probiotics. Should I stop one or the other?
I mean, I wouldn't. It depends, first of all, how you're tolerating the medications. I wouldn't necessarily recommend stopping them if you're, if it's helping you.
And Brendan makes a comment, and this is what I had thought to be true as well. Dietitians are certified and have more training than a nutritionist. What are the noticeable signs, improvements for people with a good microbiome?
So, I think with regards to Parkinson's, the things I would think of are the bloating. The bloating is the big one. And oftentimes I attributed that mostly to constipation, but I think it sort of is related to the microbiome. If you treat the constipation, though, usually the bloating gets better.
Okay, this is going to be our last question, folks. What about the timing of taking acid reflux meds, Pyrazole, Famidant with carbidopa-levodopa?
I haven't really had issues with that. I usually just recommend taking the omeprazole 30 to 60 minutes before your breakfast, for example, if you're taking it once a day. I haven't really needed to make special recommendations to time the carbidopa-levodopa around that. The drug, the omeprazole, that lowers the stomach acid, that effect lasts a long time too. So I don't think it's going to be super time sensitive. So yeah, I don't have specific recommendations for that.
Well, thank you so much, Wael. This has been awesome. We really appreciate your time. We're going to move along. Our next topic is latest advances in deep brain stimulation. Dr. Zenos Mason is presenting. Dr. Mason is a movement disorder neurologist and assistant professor of neurological surgery and neurology at the University of Southern California. His clinical and research interests are in the use and development of deep brain stimulation as a treatment for movement disorders. He lives in West Hollywood with his husband, Daniel, and their dog, Sadie, and is a musician in the Los Angeles Doctors Symphony Orchestra. Welcome, Zenos.
Hello, everyone. Good morning. Nice to be here. And so I have to say that the Los Angeles Doctors Symphony Orchestra has been rebranded Orchestra Nova Los Angeles. So I will put in a plug for Orchestra Nova, but it's no longer a Doctors Symphony Orchestra. It's a community orchestra. And we'd be thrilled to have anybody here come and attend one of our performances. So thank you very much for having me. And I think many of you have likely heard about deep brain stimulation in the past. This is a topic that comes up a lot. Practically speaking, it's because DBS is a lucrative technology for the companies that supply it, and so they're often excited to make talks and education available to the public. Now, as a clinician who treats patients with DBS and is very interested in deep brain stimulation, that's great for me because I get the opportunity to speak to people with great frequency, and so I'm often presenting this information to people. It's also good for the community because it gives you an insight into how DBS can be helpful. But this is, it's one of many important topics in Parkinson's disease. I say all of that to say that you may have heard some of this basic information before, but I'm going to be talking a little bit today about things that are coming down the pipeline that are quote unquote off label. So not things that you would normally hear in a device oriented or talk about DBS, because those are things that normally we can't really talk about if we're dealing with one of the device companies. So we have a little bit of a different spin today, and I hope that I can answer any questions about what you think DBS might be able to do for you in the future, or where we think the technology is going. This can be a bit more of a freewheeling conversation, and I'll try to leave as much time for questions as I can. First, disclosure. So I am employed as a consultant by two of the device companies, Abbott Labs and Boston Scientific. I've received travel fees and speakerships, no investment disclosures, no research conflicts of interest, and none of that is really relevant to the details of this talk, and I do talk about all three of the devices importantly, but that's just important disclosures for you to be aware of. We'll talk about basics of deep brain stimulation today quickly, because I think this is something that many of you have already heard about, and then talk about some of the alternatives to DBS that are coming down the pipeline or that are available now. Then how genes are going to become integrated into deep brain stimulation care. This thing called adaptive DBS that I hope you'll understand at the end of the talk, image guidance in deep brain stimulation, and then remote DBS programming, which is new as of the last few years. Starting with deep brain stimulation basics. Again, probably information that most of you have seen before, but there's three components to a deep brain stimulation system. There is the electrode that's implanted in the brain, deep in the brain, hence the name. That's implanted through a hole which is made in the skull, which is about the size of a dime, made by a neurosurgeon, that connects to wires that run under the scalp, under the skin, down the neck, and attaches to a battery, which is very much like a pacemaker in the chest. That battery supplies continuous electricity to the system. It stimulates one particular area of the brain with the goal of relieving symptoms of Parkinson's disease. So here are some examples of the implanted batteries. Here are some examples of the lead. These are about the diameter of a piece of spaghetti or spaghettini. It's even actually thinner than a typical piece of spaghetti. So it's about 1 millimeter or so in diameter. And this is the entire system on the right integrated into somebody. So obviously this is invisible, but it is under the skin and remains there permanently. The battery comes in and out once every few years. We're still figuring out exactly how deep brain stimulation works, but at a broad 10,000 foot level, how it works to relieve symptoms and improve function is by reducing fluctuations. So many of you have excellent response to medications, those of you with Parkinson's disease. Some of you might be experiencing some off time or some excess movement, which is what in the field we call dyskinesia. And then some of you may be experiencing swings from off time to dyskinesia with not a lot of good time during the day. That's when deep brain stimulation can be very helpful. With generally the same doses of medications, it allows people to have more time during the day in that good on time without excess movements or dyskinesia. Am I a candidate for deep brain stimulation? This is a question that I get very often. So here are the basic criteria that we use to determine if somebody might benefit from DBS implantation. First is that the underlying diagnosis is Parkinson's disease, and we want to be sure of that because some other disorders that look a lot like Parkinson's disease at the beginning can go on to progress differently over time. So for that reason, because it's difficult to differentiate between these disorders at the beginning, we usually reserve deep brain stimulation for people that have been diagnosed or at least have had symptoms for about 5 years. And if there's the typical symptoms and it's progressing in the way that we think, then we're sure enough that it's Parkinson's disease, and then we can move on with deep brain stimulation. The other very important factor is that the symptoms respond to medications, and this relates to the likely effect of DBS being typically about the same as, but no better than, the best effect of the medications. That effect is just maintained for more time throughout the day. We also want to see that people have these fluctuations, these ons and offs, and that the symptoms that are bothering them, that are affecting their quality of life, this is point 5, are the symptoms that are responding to medications. So sometimes some symptoms get better with meds, but the real symptoms that are most bothersome, they don't really fluctuate with medications throughout the day. We want there to be a really good match between the symptoms that are functionally disabling and the symptoms that are responsive to medications. We want those to be about the same. And then sometimes if people are unable to take medications for Parkinson's disease because of side effects, that's another situation where DBS can be useful. There are 2 ways to go about the surgery. There's asleep DBS. This is the classic way that's been done for a couple of decades now, where we use brain signals and we use an intraoperative examination. This is the awake procedure. Brain signals and intraoperative examination. So you wake up during the surgery in order to make sure that that electrode is in the precisely right place. The other technique, which we use at USC and is used in some other places throughout the country, is called ClearPoint Asleep DBS. This is entirely done within the bore of an MRI scanner. And so the person does not have to wake up. These 2 techniques have equivalent outcomes. So the method is really just between you and your neurosurgeon in which you would prefer. But a sleep DBS offers the advantage of if you're very nervous about waking up during the surgery, you can just stay asleep the whole time and not have to worry about that. These are the devices that are available. They're FDA approved and available in the American market. The Abbott device, the Boston Scientific device, and the Medtronic device. They all have relative advantages and disadvantages, which I've listed here. I'm not going to go over them in detail. But the decision of which device to use is between you and your neurosurgeon and your neurologists. And there's no one best device, truly not. They all have good points and bad points. And so it just depends on where you live, what your symptoms are, what your priorities are. But there can be many options in these devices and ways to tailor your experience to your particular symptoms or what your goals are. There's also the option of having a single charge or a rechargeable battery. And again, advantages and disadvantages to both. Are you going to be somebody who wants to set it and forget it? Or do you want to have a battery that lasts longer and not have to be replaced as often? It's the basic decision. So both of these are available from most of the manufacturers, and in the next year or so, all three manufacturers will have both single charge and rechargeable options, more than likely. Okay, so that's all the basic information. Just wanted to make sure we all got on the same page before we move on to what's new in DBS. So some really exciting things happening over the last couple of years, and one of them is in alternatives to deep brain stimulation. So some data was released at the neurology conference, the American Academy of Neurology last year in late April on a type of therapy called continuous subcutaneous levodopa. For those of you who maybe have had a friend or a loved one with type 1 diabetes, you may be familiar with continuous insulin pumps. So these are pumps that go under the skin. They deliver insulin continuously in response to changes in blood sugar. And this same kind of technology can deliver other medications, and one of them is carbidopa-levodopa, or Sinemet. Obviously, it's not in a tablet form, but in a different formulation that can go under the skin and dissolve and be absorbed. And this continuous infusion has the potential to reduce the fluctuations and the dyskinesias. Because when you take a pill, you take 100 milligrams of levodopa at once. This kind of infusion gives you a slower, more gradual, more continuous infusion of levodopa, and so can sort of do the same thing that deep brain stimulation can, but with medications instead. So two companies are marketing these continuous infusions under the skin. So it involves a small needle that's under the skin for continuously, basically for long periods of time, and connects to a pump. So both of these compounds can reduce the amount of off time that somebody has without developing excess movements or dyskinesias. So if tablet levodopa is not enough for you and you can't quite find the balance, continuous subcutaneous levodopa infusion could be an option. And you can see here it reduces the amount of off time by around 2 to 3 or 3.5 hours per day. And this is without dyskinesia. The major side effect, and the thing that is most concerning, is the development of what are called subcutaneous nodules. So it's basically swelling and redness of the skin, and that's due to the medication itself causing chronic irritation and probably also some contribution from the needle. So that requires that the infusion site be changed, and sometimes it would require people to entirely come off the therapy if these are particularly bad or very, very bothersome to them. So this is an interesting option that's probably going to be on the market in the next 6 months. I would expect very likely in the next 12. Another alternative to deep brain stimulation is MR-guided focused ultrasound. So this is magnetic resonance imaging, MRI, guided focused ultrasound. You've seen ultrasound scans for babies, for example, for pregnant women. A focused ultrasound takes hundreds of ultrasound beams oriented all around the skull, and you can see in this sort of half dome, this is where somebody's head would go in this device, and then there's hundreds of array. There's an array of hundreds of ultrasound probes, and they're all pointing that ultrasound energy at one point in the brain. So from the outside of the skull, the ultrasound can penetrate the skull without any holes, and focusing all of that on one area of the brain, it causes heating. And that heating causes death of that very small area of brain tissue. And we're talking maybe a centimeter by a centimeter, so quite small, about the size of a dime, or maybe even half of that. So this is a lesion. It is a non-invasive lesion, meaning we don't actually have to drill into the skull. We don't technically have to cut the skin, although there are points where the head is fixed in a frame, so it's not comfortable, and all of your hair needs to be shaved off. So it's not technically invasive, but it is definitely very involved. But the beauty of this technique is that if somebody is very sick because of medical disease, or maybe heart disease or lung disease, and they can't undergo a surgery because of these other disorders in addition to their Parkinson's disease, this offers a way to this offers a means of treatment that can produce some things that are similar to deep brain stimulation, but with less procedural risk. So less in somebody who's otherwise unable to undergo surgery, this might be a good option. So what kinds of things does this technology allow us to treat? Well, one is tremor. So we can treat one side of the body by lesioning or burning a hole in the brain in an area that's important for tremor. And another is dyskinesia, so those excess movements. There was a recent study published in the New England Journal of Medicine this year, and you can see a graphic from that study here on the right side. So it looked at about 70 people, right, who were treated with this technology, who had fluctuations and dyskinesias. And of those patients who actually received the therapy, about 80% had persistent benefit in reduction of those fluctuations and those excess movements over the period of follow-up. The downside is that there was about a 10% risk of permanent side effects from this procedure when we burn a hole in the brain in an area that's important for excess movements and fluctuations. And those could be difficulties with speech or a little bit of weakness on one side of the body. So because this is technically non-invasive, but we're still burning an area of the brain, it's different than deep brain stimulation, where the electrode goes in, it delivers electricity, it can disrupt or modify the activity of that area, but it doesn't actually kill the brain cells. And so any side effects of deep brain stimulation, or the vast majority of the side effects of deep brain stimulation, are temporary and can be adjusted by changing the electricity. The downside of MR-guided focused ultrasound is that once you burn that area of the brain, it's not coming back. So those side effects have the potential of lasting longer or being permanent. But there can be some real advantages to this. And I think in people who can't undergo surgery, like I was saying before, this offers a really important tool to improve symptoms of tremor, excess movements, and sometimes off time. So we're going to move on from alternatives now with our last 5 minutes or so, talk about genes, and then go on to some of the new technologies. Genetics of deep brain stimulation are just beginning to be studied. This is an interesting paper that was published about a year ago, looking at the effect of one gene, glucocerebrosidase, GBA, which is an important mutation that's found in some people with Parkinson's disease, and the effect of that gene on the effect of DBS. So GBA is known to increase somebody's risk of cognitive changes over time. And this group found that in the patients with GBA mutations, once they underwent deep brain stimulation, there was an increased rate of cognitive decline. So looking at the purple line, those are the people with the GBA mutation who had DBS. And the other three groups are basically no mutation or no deep brain stimulation. So a lot more cognitive change over time as measured by this MADRS scale. Most of this, though, it was actually inferred. So they followed people for a very short time. It was about a year. And then they inferred the trend based on that 1 year of follow-up to 15 years. So the difference isn't nearly as much as they have implied in this figure, but there is some data to show that some genes might change your response to deep brain stimulation. And I wanted to outline a couple of really important and exciting things that are being done by the Parkinson Foundation and the Michael J. Fox Foundation. One is the PD Generation Study, which you can sign up for free. And the other is the GP2 program. And both of these are aiming to increase the amount of genetic information we have from people with Parkinson's disease across the entire population. And there's been a major issue in the field of research in the last 2 decades, being that most of the genetics that we have are from people who are white. And there's very good evidence to say that people of color have different genetic risk factors and may respond differently to some genetic mutations. So as we broaden and sort of diversify the pool of genetic information, we have more and more important and interesting data to use to predict people's response to different therapies, how they might progress over time, and maybe in the future, how they even might respond to deep brain stimulation. So here are the few of the genes that are being tested by the PD Generation program. Again, this is something you can sign up for and undergo genetic testing for free. Just a little bit of information about each one of these genes, but these are some of the more important and more common genetic risk factors that are present across the entire population. And this is something you can sign up for free if you go to the Parkinson Foundation website. So I want to introduce you in our last few minutes to the idea of adaptive DBS. So what is adaptive DBS? Well, think of it as the same thing as a thermostat. Okay, so how does a thermostat work? You might remember these old model Honeywell guys where you actually turn the dial, and now we have fancier smart systems. But it basically takes the input of the temperature of the room, and it uses that temperature to turn the furnace on and off. So you're using some input signal, and in a thermostat it's the temperature, to modify the output, and in a thermostat that's the activity of the furnace. All right, so then the furnace turns on, the temperature of the room goes up, the thermostat moves a little bit, turns the furnace off once it gets to a specific temperature. So this is the idea of using adaptive DBS, or we're using certain signals in the brain or other signals to change the stimulation. So what are we actually using? Well, one of the inputs is brain cell activity in surrounding the electrode. It's technically called a local field potential, but it's basically the activity of about 10,000 nerve cells around the electrode. We can measure those nerve cells. And here, in this figure here, you can see that when the activity is up here in this upper range, down here, the stimulation is increasing. So everywhere you see a triangle is where the stimulation has been triggered to increase by a high activity on this upper graph. And then here, we're in this good narrow range where we want the brain cell activity to be. And then once the brain activity dips down on its own, that triggers the stimulation to decrease. Okay, so this is something that has been studied. It is possible, and it's actually on the market now by the Medtronic system, which is capable of measuring brain cell activity. And this here you see on the left side is one of the kinds of graphs that we can get, some of the information we can get from the system that is currently on the market. And there's been some preliminary data from a trial of adaptive DBS, which is called ADAPT PD, which came out in Copenhagen in the Movement Disorders Society conference just a few months ago, showing that there was a similar amount of on time, possibly less energy usage. And we're going to get more and more data from that trial to show if potentially this could even be a bit more beneficial than traditional deep brain stimulation. Again, using that brain cell activity to modulate the activity of the deep brain stimulation system. So that adaptive loop. But what other signals could we use? Maybe not just that local brain cell activity. Could we also use activity from wrist monitors that directly measure tremor in order to trigger the deep brain stimulation or change it? Could we use other brain signals, like this is called electrocorticography, but this is measurement of brain signals from the surface of the brain rather than deep in the brain. Lots of different things could be used to modulate the stimulation or the strength of stimulation. So what about image-guided deep brain stimulation? This is new, and it's newly integrated into our programming process. This is how we manage deep brain stimulation. But here you see on the left side, these little colored bubbles are not sort of artificial template areas, but this is actually the patient's anatomy reproduced in 3 dimensions on our programming tablet. So if you come to see me in the office, we'll get the right kinds of scans, we'll combine those scans, we'll upload them to the tablet, and then I will see where the electrode is in your individual anatomy. It's almost like I'm looking into your brain to see exactly where I should put the electricity and how I should change things. Now, is this completely 100% reliable? No. It's a very useful tool. And with the caveats that there's a lot of assumptions that go into these reconstructions, we can use this information very productively to program more efficiently, to get symptoms treated faster, and to understand where side effects are coming from. So this has just been introduced to our process in the last year or year and a half, and we're finding that people are very happy and very satisfied using this in our practice at USC. and also around the country that people are adopting this very quickly. So we might also be able to use different features of brain anatomy in the future when we might actually be able to use the wiring in the brain, which we can't easily see on an MRI, but we can reconstruct, to target stimulation to connections. So not just regions of the brain, but the wiring that connects different regions together. This isn't something that's available now, but it's something that there's a lot of interest in the field. And I think all of you are probably familiar with the capacity of the Abbott device to offer programming remotely. So just one system offers this right now. It's possible that the other manufacturers will come out with this in the future, but right now this is just the Abbott device that allows us to connect to a patient from the office over the internet in a secure portal and change the programming from afar over the internet. So somebody can be at home 100 miles away from us in the office. We can see them, make a direct connection with their device, and then change things. And through a video link, we can see the effect of those changes remotely. So this is, again, something that's not very new. It's been around for about 3 years now. But for patients who are at a distance and can't come into the office very easily, or perhaps limited by their mobility, or just don't want the inconvenience of parking and driving in, this is a really nice tool for us to have at our disposal. Here are the 3 takeaways, and let's do questions.
Is DBS effective if a person has a variant dopamine deregulation syndrome?
Well, dopamine dysregulation is usually a behavioral symptom. So that's something where somebody will sometimes be compelled to take more medication than perhaps they were prescribed because of emotional or neuropsychiatric sort of symptoms, or they're that's sort of a separate category of things that DBS is not designed to treat. Now, could it be appropriate in somebody who has that symptom, that set of symptoms? Maybe, but it wouldn't be for the compulsion to take more medication.
What about DBS and the LRRK2 mutation?
Yes, so there is a little bit of evidence on LRRK2. The evidence is just a small sample size, so it's not of great quality. Probably is the case that DBS is just as effective for the LRRK2 mutation as others, but it may be differently effective on specific symptoms, like cognitive symptoms if they're present.
I have RBD. My Parkinson's symptoms respond very well to meds. Some neurosurgeons have told me I am a poor candidate for DBS because I also have RBD. What is your opinion?
So let's leave the individual candidacy questions aside because there's so much nuance there. But yeah. DBS is not designed to treat REM sleep behavior disorder.
Side effects can't be ignored if you want to make an informed decision. What of these options have the least risk of serious side effects?
Well, that's also a very difficult question to answer in a short period of time. I will say that deep brain stimulation probably has the longest track record of anything else that I've talked about today. When I mention the alternatives, it really is in people who don't want to undergo surgery or can't undergo surgery. So if you want to go with something with the longest track record, or at least the most understood safety profile, then DBS is the best option because we understand it. It's been around for 2 decades. We know what the risks and benefits are clearly. Some of these newer therapies, they might have a lower short-term risk of side effects. For example, levodopa under the skin. Obviously, you're not doing a brain surgery, so there's no risk of bleeding or infection. But the efficacy may be different. Right? So it's a very individualized conversation. I think MR-guided focused ultrasound, for example, has likely a higher likelihood of permanent side effects, but a lower likelihood of procedural side effects. So I think it's tough. You need to talk to your surgeon and your neurologist about exactly which side effects are the most important to you.
Along that topic, have there been any focused ultrasound experiment on older women, Parkinson's, on freezing gait who take Cinnamate?
Freezing of gait is not something that responds to any of these therapies very well.
You know what? I'd like to give you a chance just to go over your 3 takeaways for the group.
Yeah, sure. Well, so I think I'm just going to leave them up on the screen and we can continue answering questions because it really is pretty simple topic based. I mean, genetics we talked about, the individualized brain anatomy image guided programming is very important in the process. and that's integrated into most DBS practices. And we'll see a lot of advances in hardware over the next few years, especially most importantly, those adaptive systems. But those are just the three takeaways.
Is this similar to the Gamma Knife?
MR-guided focused ultrasound is in some ways similar to Gamma Knife, but a superior option for a few reasons.
All right, everybody. Well, Dr. Zenos, thank you so much for your presentation. This is some awesome new information. So thank you for joining us today. And just a quick reminder, to all that the donation links for PCLA can be found in the chat. Our next topic is under the radar, Parkinson's symptoms you should know. Dr. Nicholas Somsky is a fellowship-trained movement disorder specialist within the Cedars-Sinai Medical Group. As the chair of PCLA's Medical Advisory Board, he has been with us from the beginning and continues to advise us on all current medical issues that affect those living with Parkinson's. Thank you so much, Nick, for being here today.
Thank you, Patrick. I'm very happy to be here. Again, welcome to everybody, and thank you for having me. The topic that I'm going to approach today, we sort of nicknamed it Under the Radar Parkinson's Symptoms. And the goal is to maybe talk about some things that may catch you off guard, may surprise you a little bit, maybe to find out that they are related to Parkinson's. And hopefully, if they are familiar, if you think, hey, I think we may be dealing that to myself or somebody that I care for with Parkinson's, could generate some good conversations with your treating physician. A quick disclaimer, by necessity, because Parkinson's is a multi-layered disorder, I'm going to mention a lot of things in this segment. I could probably talk all day and barely scratch the surface of Parkinson's if we tried to go in too deeply. So keep that in mind. Some of the things we'll talk about, I'm going to go back by pretty quickly. And so that's just out of necessity here. I also want to mention that although there are many, many commonalities among patients, there are a lot of things that people share among each other in terms of symptoms. Individual experiences vary quite a lot. So things we talk about today are not meant to be a forecast, a prediction of what you will experience or when you might experience it. So I don't want this to sound like a litany of, here are all the things coming down the pipeline for you that can seem a little overwhelming. Instead, I hope it just raises some awareness of some things that can come up in Parkinson's that may be worth some extra attention, or at least a different framework of thinking about them. Generally speaking, you're probably all familiar that we tend to divide symptoms of Parkinson's broadly into motor and non-motor symptoms, which is an effective starting point for discussing what kind of things can be affected in Parkinson's. The motor symptoms, they start with the so-called cardinal symptoms. These are the ones that sort of make the core diagnosis: rigidity or stiffness, bradykinesia or slowness, rest tremor, which is, interestingly, although the most famous symptom in Parkinson's, is not actually present in everyone with Parkinson's. Postural instability, which tends to develop later and leads to imbalance. But these are the famous ones. These are not under the radar. So I'm going to move on. Here are some other fairly common ones that a lot of people have dealt with and have probably heard of. Micrographia, or having difficulty with handwriting. Changes in the voice, so it's softer, it's harder to project, and sometimes takes on a raspy or gravelly quality. Masked faces, a fancy way of saying that you just don't show expression on your face in the same way that you once did. There are a lot of changes in gait or walking that can be seen in Parkinson's. The famous shuffling gait, tendency to stoop forward, freezing, which was just recently mentioned in a question, all those and more. There are other aspects of gait that can be affected by Parkinson's. And of course, dyskinesias, which are when you get extra movements, involuntary movements as a result of Parkinson's and usually medications that you're on to try to treat it. Again, these are pretty par for the course. I think many people are familiar with them. So I want to talk about some things that may fly a little bit more under the radar. And so the first one I want to talk about briefly is dysphagia, a fancy way of saying swallowing problems. When I think about swallowing problems with patients, I tend to divide it into two categories. One is pretty common but not terribly concerning, frustrating perhaps. And the other one is of the more worrisome type. So the more common one is that the timing of initiating a swallow after you're done chewing, or perhaps you put a pill on your tongue and you're ready for it to go down the hatch, getting that timing to work out can be affected in Parkinson's. And so the common problem with swallowing that a lot of people have is just getting things to go. Find yourself chewing and you're like, okay, any moment now, I'm just going to swallow this. And people will sometimes just describe this difficulty in getting it to actually happen. That's usually benign in and of itself. It's more of just a frustration, because you may find you have to come up with strategies to try to help the food along, like sipping water or putting a pill in applesauce or yogurt to help generate the trigger to send it down. The more concerning type of swallowing problem is the kind where if food or more commonly liquids like water go down the wrong pipe, things that enter the lung can be a source for infection and so forth. And so if you have swallowing difficulties, or if there are concerns about swallowing, if you have coughing or choking, your doctor may investigate that with a swallowing study to try to help identify the nature of the problem. And then usually a speech therapist can give you some advice on how you might change your approach to eating and drinking, dietary changes, thickeners, things like that, that might help reduce those risks. Next, I want to just touch on drooling, which is fairly common. This and the next one are, they share kind of a common cause, that we don't realize how often we spontaneously swallow throughout the day. I remember a factoid that I learned back in medical school, and it stuck with me because it was so vivid, and hopefully it's also true, but basically it was that we swallow 1.5 liters of saliva every day. Kind of gross when you think about it, but it means that it's really important that this system be engaged readily, because your body, your mouth is sort of prepared for the next meal. There's some saliva being formed, and it tends to build up if you don't constantly swallow. And usually that swallowing takes place without us having to think about it very much at all. But with Parkinson's, that system tends to slow down, and spontaneous swallowing slows down. And so without the swallow, the saliva production can basically start to pool in the mouth. And all it takes is a little lean forward or tilt to one side, and the saliva can then spill out. And so strategies aimed at this can include anything from just kind of reminding yourself to swallow, or taking sips of water or a small snack or something to help induce a swallow to kind of empty the pool that's formed there. And when it's really problematic, it can even involve using botulinum toxin injections to try to dry up saliva production to some degree to help reduce that problem. But there are definitely, it can be a very frustrating symptom, particularly socially for a lot of people, but there are definitely treatment options to be discussed. In a similar way to the fact that we, in Parkinson's, see less spontaneous swallowing, we also have a decreased spontaneous blink rate. The eyes just tend to spend more time open. As a result, they tend to dry out. But ironically, at the same time, you may see tearing, not from emotional tearing, but just pooling of liquid tears that spills out, even as your eyes feel dry. And I always like to use the analogy of if you have a dysfunctional windshield wiper fluid dispenser, and instead of spraying all over your windshield so it can be wiped over the surface, it kind of, if it just ends up puddling at the bottom and your wipers are going by over a dry surface, you end up with both dryness up here and a puddle down here. And that is kind of the analogy of why people can have an experience that their eyes feel dry and irritated and red, but they're literally also wet because the tears are coming down. They're not being distributed. Here again, the most straightforward approach might be just to remind yourself to do some extra blinking at times. Artificial tears can be helpful, and there are other strategies, but some people are actually just kind of surprised to find out that this is somehow related to their Parkinson's. They may be sort of frustrated to not know which doctor to talk to about it. I'm going to move on to some non-motor symptoms now. And these are ones that, again, each one of these could be a lecture or even a series of lectures in and of itself. But these are ones that are pretty common and you are probably familiar with. Parkinson's is associated with a higher risk of depression and anxiety. It can even predate the motor symptoms and the clinical diagnosis. Sleep can be disrupted for many reasons, ranging from circadian rhythm disruptions to Parkinson's symptoms that keep you from feeling comfortable. So insomnia is a common issue. REM sleep behavior disorder, acting out dreams, also very common in Parkinson's, also can precede the symptoms, but a very treatable condition. Orthostatic hypotension, the tendency for your blood pressure to be poorly regulated. So it may go from too low to too high and everything in between. And this is a part of a pattern of autonomic dysregulation or a loss of the automatic systems that control involuntary systems of the body, things that aren't under your control. We don't get to decide our blood pressure, but your body is constantly detecting what the blood pressure ought to do and how it should adjust to account for that. I like to sort of point out how challenging, if you think about it, it is every time we stand up. All of these liters of the fluids in our body want to go straight down to the ground because of gravity, and your body has an amazing and complex system to try to keep that from not happening because we need the blood to stay up here. And so when the system doesn't work as well as it needs to, orthostatic hypotension is a common result. Bowel and bladder dysfunction are also common. I'll kind of leave it at that at this juncture. On the cognitive side, these are things that usually tend to appear later in the diagnosis if they do present themselves. Hallucinations, seeing things that aren't there, delusions, having fixed beliefs that are not based in fact. Those can become very problematic in some patients. And then a word about one that I think frightens a lot of people, the idea of dementia, but cognitive decline in Parkinson's can be seen typically after many years with the diagnosis. I want to talk about some more under the radar versions of these same categories though. And so these, you'll notice I kind of stepped away from some of the medical terminology in many of these cases, because these are in some ways like stories that come up a lot. So on the mood side, it's negative thought patterns are a common problem in Parkinson's. And it's not necessarily that people are just, in a bad mood, although depression, anxiety can definitely affect mood. It's almost like it's hard to not think of what could go wrong. And in fact, when somebody is being diagnosed and treatment is being offered for the first time, sometimes one of the obstacles to starting treatment that some of you may have gone through yourself or maybe even going through is a sort of a feeling of distrust about the idea of medication, even the medication that would ironically help alleviate that feeling. And so on a lighter note, it can be a real challenge to, for instance, I've seen couples have a real challenge planning a vacation, for instance, because what starts out as like, hey, wouldn't it be fun if we went to so-and-so and such place, can turn into a series of what ifs, like, well, yeah, what if this happened, and what if this happened, what if they're not ready for this, and what if they don't have that? And while thinking about those things is definitely part of the planning stages, you want to plan ahead. In Parkinson's, it can sometimes seem paralyzing. You can find that the what ifs are almost endless. They're hard to dismiss sometimes. And so I think that's important to know about, because that may be something that has frustrated you or a partner. And I do talk with patients a lot about how some of that is Parkinson's, is not somebody trying to be negative. And related to this is the fact that in many patients with Parkinson's, when their medicine is worn off, when the medicine is not working well, so they're in a state of dopamine deficit, that feeling can be a very uncomfortable, unsettling feeling. And I'm pointing to my chest because patients often do describe that it's something inside. It just something feels wrong. And it can range from being a little unsettled, a little uncomfortable, all the way up to acute, almost panic attacks when the dopamine level drops. which can result in sort of abrupt behavior changes. People, I've noticed sort of a homing instinct. People may suddenly decide that we have to go home right now, and it's hard for them to put a finger on exactly why. They just don't feel like they're safe or it's okay to be there. It can also take on a more sort of depressed tone. I have one patient who more than once found himself in the emergency room when he wore way off his medications, and during that state basically felt despondent about this. My Parkinson's will never be treated. My medicines don't work, and what is kind of interesting, but also challenging and kind of sad about the symptom, is that it can seemingly erase a lot of good times and good things. And so what I mean by that is a patient who has, if you have a day that's full of success with your medications, you're out, you're about, you're accomplishing things. If later in the day, for instance, your medicine were to wear off, not only do you feel bad, but you could feel as though you've always felt bad. And instead of acknowledging, like, I had a good day until this happened, people actually, the language that they'll use actually suggests that the whole day was terrible and they don't have any good times. It almost erases that concept. It's so intense. Interestingly, when it ends, when the medication comes back on board, sometimes the partner can be like, wow, you seemed like you were in such a bad way. You wanted to call 911, you wanted to go to the hospital. And patients will, in some cases, sort of be sort of underwhelmed by what happened. Say, well, no, it wasn't that bad, and leave everybody scratching their heads. But you just sounded like it was terrible, and now you're saying it wasn't that bad. And so if that's confounding and you're frustrated, why, I don't understand what they're telling me. That one minute they feel we're having a good time, the next they feel like their medicine never works, and then it's over and they sort of dismiss that it happened. Those patterns can be very real and very Parkinson's related. There aren't easy answers to them except to try to avoid the dopamine deficit, to try to avoid that off state. But half the battle is recognizing what the heck is going on, because it can be a very puzzling pattern of behavior for people around the person with Parkinson's. And in fact, I think it's somewhat puzzling to the person with it too. Moving on to sleep changes. I put sleep apnea on here because although in my training, sleep apnea was not often listed in textbooks as something we commonly see in Parkinson's, experience tells me otherwise. I think sleep apnea is probably under-recognized in the general population, not just in Parkinson's, but I think it can be a particular issue in Parkinson's, partly because some of the motor functions of controlling muscles in the back of the mouth and airway can actually affect breathing through that airway. And I've seen many cases of sleep apnea in Parkinson's, so I'm very tuned into trying to screen for it and treat it if present. I've also seen a remarkable number of cases where people who had even severe sleep apnea, when we got their medications tuned up just right in terms of how their daytime symptoms looked, later on we found out that they no longer actually had sleep apnea. Controlling their motor function better with medications actually seemed to address the sleep apnea. Now, that's not true in all cases, but it's a sort of interesting pattern that's worth noting. If your sleep quality doesn't seem up to snuff, and by that I mean, in particular, if you feel like, hey, I get enough sleep, I don't understand why I don't feel well rested in the morning. There are a lot of problems that can go on in sleep, but if you can start the sentence with, I get enough sleep, but I don't feel like I got enough sleep, this may be a question worth exploring with your doctors. The other one I wanted to put here is something that I feel like comes up fairly often with patients as time goes on. And I tried to come up with the best phrase to describe it, and I think this is the best I could do. It's recalling dreams, vivid dreams, which are common in Parkinson's, as though they were real memories. And that can produce some confusing results. I had a patient once, I'll try to tell the story quickly, who told me that one day he saw his neighbor in the driveway. He went out and told his neighbor, he apologized to him, and he said, I'm really sorry about last night. I realized I talked your ear off. I didn't let you go. I want to apologize for having taken up so much of your time. talking about our feral dog problem. And in fact, I checked with his partner, there was a feral dog problem. However, the neighbor surprised my patient by saying, like, he was saying, I just arrived from out of town. I wasn't here last night. And that left the patient in a state of confusion of having this distinct memory of having this conversation, which was plausible. It was with a real person, a real identity, and the topic made sense. They had a real feral dog problem. He remembered a conversation that the neighbor basically apologetically explained did not happen. And so my explanation for that, and in other cases, is that he's recalling a dream, a vivid, plausible dream, something that really could have happened as a memory. And the sort of interesting characteristics of episodic memories, if you think back to, you know, what you ate for dinner last night, or the last time you went out for a major holiday, or maybe Thanksgiving dinner, it has sort of fuzzy edges. You don't remember necessarily everything leading up to it or after it, but you remember the core memory. And I think you can extract memories from dreams like that too. And it can be confusing sometimes trying to tell the difference. And this can be confused with dementia or delusions. The patient I was talking about, his memory is actually very intact and his processing is intact, but it's like he gets information inserted into the stream that doesn't belong there because it came from a dream, that he doesn't know that it came from a dream. So that's sort of a complicated, multi-layered symptom, but it's to me, it's one of the I think it's a really important thing, a distinction to be able to make, because it can really be the difference between calling something a delusion or hallucination, or saying like, no, I think you're remembering a dream very well. On the theme of autonomic dysregulation, a couple things here. One, temperature dysregulation. Thermostat was mentioned earlier. In a different context here, it's the body's thermostat, the ability to adjust to ambient temperature. And in Parkinson's, it can get fouled up. And so a common problem that patients and their families may be aware of is in one state where the room temperature hasn't changed, they can go from it's too hot to it's too cold to it's too hot to it's too cold. And meanwhile, everyone else is experiencing really no change, and it feels just kind of okay. This one can be a challenge. I think, again, just recognizing that Parkinson's is kind of playing tricks on your thermostat is part of the battle. And I would suggest starting with dressing in layers. Just have something that's easy to take off, easy to put back on. That's one of your best strategies to try to address this. I put constipation again, because I mentioned bowel and bladder dysfunction on the previous slide. I wanted to put it here because constipation is very common and many, many people are well aware that they have it. It usually does not fly under the radar, but sometimes it does. It's so common in Parkinson's that I think it's worth, in a sense, kind of assuming that everyone with Parkinson's has it. It just may not have gotten you into trouble yet. And so it's something worth keeping in mind. I had a patient recently who insists that she doesn't feel like she has constipation, but she's been dealing with things like hemorrhoids, for instance, which can be from a lot of straining when you try to pass stool. And what she calls normal, I think a lot of people would call difficulty having bowel movements and having to strain and force and so forth. So I believe she's constipated, although in her definition, she doesn't feel like she's reached that threshold. So it's worth sort of, keeping in mind that it's so common almost that it's appropriate to assume you have it. And last on this slide is cognitive. A couple of things I want to mention here. One is spatial processing difficulties. Parkinson's can affect your sense of distance and location, but as a practical matter, this comes up a lot when a patient who has Parkinson's is the passenger in a car. And if you've ever been driving someone with Parkinson's and you feel like you're keeping ample space between oncoming traffic and ample space with the parked cars, but you're getting a lot of commentary from your passenger that you're too close to the parked cars, that it can be because the Parkinson's tends to make it look like things are closer than they are. And I think I've intercepted some major, relationship conflict that has centered around this, because the person honestly truly thinks you're too close to the cars. The driver may think I'm driving perfectly safely, and it can be sort of an endless loop. if there's no recognition that Parkinson's may be playing some tricks on your ability to gauge that distance. So that's something to keep in mind. And then last here, difficulty multitasking. That may be true of a lot of us in this day and age with so many things going on, but in Parkinson's, it's a particular concern, and it's something that often worries people, makes them think, uh-oh, maybe I have dementia, when in fact, what they really are describing is they're just much more easily derailed. If they're on a path, they're trying to accomplish something and the phone rings, they may find it very difficult to get back to what they were doing. It can even be hard, I find, to listen to a conversation while thinking of a question. So I notice that a lot when I'm talking to a patient, that they are, something I've said has triggered a question, and now they're trying to listen to me and remember their question. And in many cases, because I've actually asked patients about this experience, in many cases, they've lost track of both. They sort of weren't listening, but they also couldn't remember what they wanted to ask. And it can be a frustrating moment. My solution as their doctor, when there happens in front of me, I try as best I can, when I see the hand go up or sort of a sense that they look like they might want to ask a question, I try to stop talking and let them have that moment right away. Ironically, sometimes I have a hard time remembering what I was going to go talk about next, but it sometimes reduces the frustration. So I encourage, jot things down, or if you're having a conversation with somebody in your family, and this happens a lot, just be aware that trying to remove distractions and stay focused on one thing at a time can have much better results than having a lot of things going on. Before we do the Q&A, I say many of the symptoms in Parkinson's can be missed or misunderstood, sort of thought of like somebody being ornery, when in fact Parkinson's may have a lot to do with it. So communication is key with partners, with family members, with caregivers, and also with doctors. So please discuss your specific symptoms with your physician to further evaluate them. And I'll just put in a plug that I think most of my colleagues would agree with, that I highly recommend, for this reason of how complex this is, that you work with a movement disorder specialist in your care. This
is so great. We got some great questions here. Are there medications in the pipeline for cognitive issues?
I believe there are. I don't think we've seen any so far that have been as effective as we would like them to be. That's something that comes up a lot. It's frustrating that we don't have more control over that symptom. So I think there's a lot of work being done on that front, but for the time being, some of the best things we can do are make sure your medications are tuned up as well as we can get them. Make sure your mood is in the best place we can put it. Make sure you're getting good sleep, because poor quality sleep can absolutely undermine cognitive function, and make sure we don't miss other things that can affect cognitive function and aren't related to Parkinson's, vitamin deficiencies and things of that nature. So while we don't have great direct treatments, we do have ways that we can try to address those symptoms. So again, it's good to discuss with your treating physicians.
Any suggestions for slower movements?
That one, that's sort of a broad topic in a sense, because we're kind of getting at one of the fundamental symptoms of Parkinson's. So one major suggestion would be, if that's a prominent symptom for somebody, discuss with your doctors if there are ways to adjust medications to try to address that. Physical therapy, exercise, occupational therapy could all be, play important roles in trying to address that as a symptom as well.
Are you a movement disorder specialist?
Yes, I am.
Yes. Do you want to briefly just talk about the difference?
Yeah, I think movement disorders, to say you're a movement disorder specialist, it typically means you've done extra training beyond your neurology training in a fellowship designed to really focus on Parkinson's and related disorders. And I don't want to make it sound like Parkinson's is the only complicated disorder out there. There are definitely other ones, but you can kind of get the sense from a talk like this and from your own life experience, Parkinson's touches on so many factors, and there's so many interrelated considerations to take into account. The medications that help with motor symptoms can impede sleep or impede or worsen blood pressure problems. And it is there's so many interactions there that it really takes some experience and expertise to do it as efficiently as we possibly can. I will say, because I think medicine is growing increasingly complicated on a lot of fronts, more medications and so forth, there are areas of neurology that I've, over time, even though I still see general neurology patients, I'll use an example quickly of multiple sclerosis. So many drugs have come out in that field that I no longer feel like I have a up to the moment sense of how to treat patients best in that. So I would send a multiple sclerosis patient who is having any kind of difficulty. I often ask them to see an MS specialist. So I think specialty or subspecialty care is plays a role for a lot of different conditions. For Parkinson's, it's actually been demonstrated. There have been papers written and studies done. It actually, it's not just us, trying to justify our employment. It's really is beneficial.
Thank you so much, Nick. This was incredibly informative. And I want to remind everybody here that all the speakers today, including Nick, are on our medical advisory board. And Nick, I believe you are our first medical advisory board member. So
I believe that may be true, yeah.
Yes. So thank you again so much for your presentation. Okay, our next topic is the latest research on Parkinson's and insulin resistance. Dr. Michele Tagliati has also been with PCLA since our beginning, serving as our clinical research advisor and keeping us up to date on the latest in Parkinson's research. He's a movement disorder specialist and the director of the Movement Disorders CEDARS program at Cedars-Sinai Medical Center. Please welcome Dr. Tagliati.
Thank you, and congratulations to Nick for another great presentation. I wanted to follow up on his advice to definitely consult a movement disorder specialist. Parkinson's disease is progressively recognized as a complex disorder that definitely needs the attention of a specialist. What I'm going to share today is something a little bit different. These are my disclosures. I work with a lot of companies out there, but I want to make sure you understand that none of them had anything to do with the content of today's presentation. So many of you may have heard this concept that drugs that we normally use for diabetes might be helpful for Parkinson's disease, and might be a little bit puzzled by that. It's okay that Parkinson's disease is an increasingly complex disorder, but what does it have to do with diabetes? And in reality, we have been knowing for more than 60 years now that Parkinson and diabetes have a lot to do in common. This is a paper, as you can see, from June 1960, before many of us probably were born, that reported on many patients, 800 patients that had diabetes, and because of diabetes had a faster progression of both motor and cognitive symptoms. And following that initial paper, the initial alarm, so to speak, several other papers you see in 1961, 65, 71, 74, many papers showed that patients with Parkinson's seem to have an unusually high incidence of diabetes. Not only that, the patient with diabetes seems to have an unusually high risk of developing Parkinson's disease. And odds ratio is a scientific term for risk. And if you have a risk of 1, is basically the same risk that the normal population would have. But as you see in all these studies, patients with diabetes seem to have sometimes twice as much the risk of someone without diabetes to develop Parkinson's disease. And not only that, when you have diabetes and Parkinson, you seem to have somehow a worse severity of disease, and you seem to need more levodopa to treat your symptoms. And this paper by Dr. Pagano in Europe shows something even more interesting and to some degree surprising. He's very elegantly put together 25 patients with Parkinson's disease without diabetes, 25 patients with Parkinson's and diabetes, but also 14 patients without Parkinson's disease and diabetes, and 14 healthy controls. And so first of all, he found, as you can see here, the patient with Parkinson's diabetes, as it was already described in the past, seemed to have a worse condition, a worse severity of disease. And not only that, but when you do a DAT scan, a dopamine scan, those with Parkinson and diabetes on average seems to have lower uptake, so less dopamine in the brain compared to those with Parkinson's disease without diabetes. And surprisingly, just having diabetes without symptoms of Parkinson's disease shows lower dopamine uptake, so less dopamine in the brain as compared to controls, to subjects that have the same age, but they don't have either diabetes or Parkinson's disease. So there is something about diabetes that seems to is associated to the risk to have Parkinson's disease, or at least to have lower dopamine in the brain. And this is a meta-analysis, which is a study of many studies, basically a summary study, so many studies in the literature that show the patient with Parkinson's diabetes, again, a faster motor progression and worse cognitive decline. So in 2021, 61 years after the original paper, we reached in a more scientific manner with more sort of control of the data, the same original conclusion. Diabetes and Parkinson are good friends, but not your friends. And what do they have in common? Why would they be good friends? Well, unfortunately, they have a lot of risks in common. I'll show you some genetic commonalities, lower exercise and lower rates of exercise and obesity seems to have a common risk for either Parkinson and or diabetes. And obviously, both Parkinson and diabetes are diseases of aging. And in fact, aging is recognized as the worst risk factor, the most dangerous risk factor to develop Parkinson's disease, but also to develop diabetes, because with aging, the so-called insulin resistance, we'll define it more accurately in a few minutes, leads to an increased need to secrete, to produce insulin by the pancreas, and ultimately to a failure of this ability to produce insulin, and therefore diabetes. There are common genetic factors between Parkinson and diabetes, and interestingly enough, they have to do with insulin receptors, with the response to insulin, which is kind of intuitive for diabetes, but not that intuitive for Parkinson's disease. Inflammatory response genes, and again, impaired glucose tolerance. So both Parkinson and diabetes have a genetic predisposition to develop this insulin resistance. We know that physical activity increases the risk of Parkinson's disease. There are a number of studies showing that people that exercise less, or patients that have increased adiposity, so increased weight, obesity, have a higher risk of Parkinson's disease. And sure enough, obesity and lower exercise are associated with increased inflammation, increased circulatory inflammatory cytokines that then, as a consequence, reduce the ability of the body to respond to insulin. And this is, at the end of the day, the definition of insulin resistance: a reduced biological effect for any given concentration of insulin. In other words, a reduced response of our body to insulin. As I said earlier, this leads to an increased demand on the cells of the pancreas that produce insulin, that start having hyperinsulinemia, meaning there's a lot of insulin circulating. And at some point, this increased needs and increased production cause basically a death of the cells in the pancreas. The blood sugar levels rise. We have initially what we call prediabetes, or elevated hemoglobin A1C, that sort of tries to buffer this excess glucose. And even when that second mechanisms, the first one is the hyperinsulinemia, the second is the increased hemoglobin A1C. When all these buffer systems fail, we have diabetes. And diabetes and insulin resistance, without even getting to diabetes, is already in on itself a problem. There are studies showing that, for example, patients that have insulin resistance have, for example, a high risk to develop cognitive decline or dementia. in association with Parkinson's disease. We have studied at Cedars-Sinai the incidence of insulin resistance in non-diabetic subjects, so patients with Parkinson's disease that do not have diabetes, and we found that many of them, 2 out of 3, have prediabetes, so have insulin resistance, particularly those who have obesity. Almost 100% of them had insulin resistance, but even patients that are lean, that are perfectly, have a perfectly normal weight, 40% of them had unexpectedly elevated insulinemia and insulin resistance. So what's going on? And is that even relevant? So why would I care? Well, look at this study again that we did at Cedars. This is Dr. Hogg. We perform PET scans in patients with Parkinson's disease, and the PET scans can measure the ability of the brain to uptake glucose, to uptake sugar, that, as you know, is the main food, the main nutritional fuel for our brain. And you can see in the first row, this beautiful bright images. That's a lot of glucose that the brain can absorb. And in the second row, you see this dimmer image. And the top is a patient that in our study had the lowest hemoglobin A1C, so had the best response to insulin. The lower row is the one who had the worst insulin resistance, the worst response to insulin. And when we look at people with normal hemoglobin A1C versus people with prediabetes, the ability to uptake glucose from the brain was greatly reduced, statistically significant reduction in the ability of the brain to absorb sugar. This is quite relevant because the brain not only uses sugar as a main fuel, but also needs insulin for other functions, like, for example, regulating food intake, growth and differentiation of the neurons, and also ability to produce neurotransmitter and synaptic plasticity, which is fundamental for all sort of brain function like learning, memory. If we reduce our brain synaptic plasticity, that cognitive decline that we all dread is more likely. There are studies that show that there is a decrease of insulin receptors in the brain of patients with Parkinson's disease. You see the IR, insulin receptor mRNA, that is reduced in patients with Parkinson's disease, and compared to, this is the decrease in dopamine. So it's almost parallel to the well-known decrease in dopamine in the patients with Parkinson's disease, but it's not just the dopamine, it's also the insulin receptor. So it's something that we can see in patients with Parkinson's disease. So nearly half, if not more, according to our studies, of patients with non-diabetes, without diabetes, but overweight and Parkinson's disease may have insulin resistance without even knowing it, because when they get a blood samples, a routine check, their glucose is normal, their doctor may tell them that there is nothing to worry about, and instead that problem is sort of brewing inside their organism. And so the loss of insulin may create a lot of issues inside the brain, very similar to the one that we recognize at the base of Parkinson's disease, like mitochondrial dysfunction, that in lay terms mean reduced ability of the brain to produce energy, to produce calories in the brain, increased inflammation, which is now recognized as a very, very important issues in the brain of patients with Parkinson's disease, oxidative stress, and accumulation of alpha-synuclein that we all know is a major issue, probably the pathogenic, the best known pathogenic issue in the brain of Parkinson's disease. The good news is that insulin resistance, while diabetes obviously is irreversible and will need treatment with specific medication. Insulin resistance is reversible, and this is a very important message. And is reversible, probably not coincidentally, with the same lifestyle modifications that we normally promote and suggest in any patient with Parkinson's disease, meaning exercise, meaning low-carb diet, and improve the sleeping habit. But, and this is sort of the main topic of this talk, we have also started to study the possible beneficial effect of medication that can improve the sensibility of the body and the brain to insulin in order to restore the signaling that can help a patient with Parkinson's disease. There have been many studies that would be too long to summarize, so I will focus with sort of the latest and, in my mind, most important wave of pharmacological research that links diabetes and Parkinson's disease, which is the research on glucagon-like peptide, or GLP-1 agonist. What is GLP-1? Is a small peptide, only 30 amino acids, that increases insulin secretion when we have a meal. So it stays quiet for a while, but every time we eat something, it sort of stimulates an increase in insulin secretion, so that intake of sugar that we have almost invariably with the meal gets properly handled by an increase in insulin. And GLP-1 receptors are located not only in the pancreas and the intestine, where you would expect that, but also in the central nervous system, also in the brain. And so we expect that using this medication in patients with Parkinson's disease, given the issues that I just summarized, given the high likelihood of insulin resistance in the brain, might help, if not treating the disease, slowing down its progression. And in fact, there's research coming from Johns Hopkins showing that GLP-1 agonist in the brain, in the central nervous system, might be even preventing pro-inflammatory cytokines. So maybe basically an anti-inflammatory action that can prevent the pathological degeneration of the brain that we see in Parkinson's disease. So what have we seen? There have been several groups that have, including our group at Cedars-Sinai, that have tested this GLP-1 agonist in Parkinson's disease. The first one was the group in London, led by Tom Foltini, that, as you see, already 5-6 years ago, published this seminal paper on the Lancet, showing the patient that had been randomized to exenatide in blue as compared to those who had been randomized to placebo in red, had a much more favorable response. So you see they had actually a decrease in the MDS-UPDRS part 3 in the motor score of Parkinson's disease as compared to those with placebo that sort of continue to get worse over time. Not only that, but when they performed a DAT scan, a dopamine scan, those who had been randomized to exenatide, to the GLP-1 agonist, seemed to have a lower progression, like their ability of their brain to uptake dopamine seemed to remain stable, while those randomized to placebo kept on getting worse in their ability of uptake dopamine. We at Cedars got interested in another GLP-1 agonist called liraglutide. And why were we interested in liraglutide? Because in patients with diabetes, liraglutide seems to be more powerful than exenatide in reducing insulin resistance and improving, therefore, diabetes, and also causing some reduction in body weight. This, by the way, these medications are very similar to a medication that had made a lot of headline, Ozempic, that is used specifically to lose weight. So based on these results with liraglutide, we started to test with a controlled clinical trial at Cedars liraglutide, which is an injectable. It needs to be injected every day. And we tested in 63 patients with Parkinson's disease that were randomized to receive either the active drug or placebos. It was a double blind, so neither the patient nor the observer knew what they were taking, in a 2-to-1 study design, meaning the two study subjects were receiving the active drug and one was receiving the placebo. We completed the study and with 63 subjects that were enrolled. 12 of them were withdrawn, meaning they stopped the study before the year duration. 7 due to side effects, we'll see which one. 4 due to adverse event that had nothing to do with the drug, and 1 because started taking a medication that was not accepted in the study. First interesting results, even if it was, as you see, NS means non-statistically significant, non-significant, but those who had been randomized to placebo in orange seemed to need more levodopa at the end of the year. And so again, even if it's non-statistically significant, it sort of gave us some idea that those who were taking placebo needed more care, more dopamine supplementation than those that were taking the active drug, the liraglutide. We went to look at the motor score, similar to the English group, and we found something surprising. So the blue line shows the liraglutide, and we can see that similar to the English group, we saw that patients with liraglutide seem to have less need for, lower motor scores as compared to the beginning of the study, the baseline. However, that was true also for the placebo patients. So we had what we call a very strong placebo effect, which unfortunately is not uncommon in studies that include patients with Parkinson's disease. And placebo, the expectation of the results can increase in and itself the dopamine in the brain. But that scientifically, from the clinical trial standpoint, made whatever observation null. There was a strong placebo effect. From a cognitive standpoint, in collaboration with Dr. Wertheimer, that you will hear from later, we studied the cognitive function of these patients, and we saw that at the end of the day, there was no difference between placebo and active drug. There is to say, however, that fortunately, most of these patients were perfectly normal to start with. So it is what I would define probably a ceiling effect. You can get better than normal, but definitely nobody got worse. What was interesting and surprising, especially after what we heard from Dr. Sumsky, is that the non-motor symptoms, the scales that we use to quantify the non-motor symptoms, showed a statistically significant improvement in the non-motor symptom scale, so patients that were randomized to liraglutide compared to placebo. And this was quite interesting because, as you can see, the orange being placebo and the blue being the liraglutide, basically all the subscales, so all the non-motor symptoms, you see them here: cardiovascular, sleep, mood, cognition, gastrointestinal, etc. All of them seem to be favoring the active drug, with the particular attention to attention and memory, so cognition, that was the one that actually had even statistical significance. So attention and memory, similar to what had been originally observed by the English group of Dr. Foltini, seem to improve in patients with that were randomized to the active drug. Interestingly, secondary outcomes, for example, the global MDS-UPDRS, that is not just the motor score, but also the non-motor score and the activity of daily living, seem to favor, as you can see here in blue, the liraglutide group. The activity of daily living, which is a very important measure because it's the subjective experience of the research study patient. So what is perceived as an improvement, I feel better, I don't feel better, was dramatically better. And it was dramatically better again in every study subdomain, particularly for activities like leisure activities, turning in bed, getting out of a car, walking in balance, and freezing. And last but not least, quality of life.
Excuse me, Dr. Take-Aways, we have 2 minutes. Sorry.
2 minutes, I'll be very quick. Also, quality of life measures, as you can see, were much better in patients assigned to liraglutide as compared to placebo. Body mass index decreased, that was expected. Basically, patient lose a little bit of weight, and also hemoglobin A1C, so element. The side effects were limited to some nausea and loss of appetite, which were expected based on what we knew about these medications. And I just want to spend the last minute looking at 2 other very recent studies. This is lixisenatide, is another GLP-1 agonist that was tested in France by a multi-center study that was recently presented at the Movement Disorder Society. And in conclusion, they found, similar to the English group, that lixisenatide had a beneficial effect on motor progression in patients with early Parkinson's disease, which suggests a possible disease-modifying effect, although they were careful to say that this should be studied further. And last but not least, another GLP-1 agonist, NLY-01, instead failed to find a difference in motor or non-motor outcomes, although they found the patients that were younger than 60 seemed to have a more beneficial response than those older than 60. So in conclusion, type 2 diabetes appear to risk a risk factor for Parkinson's disease and associated worse symptom and progression. Insulin has an established yet unclear role in the central nervous system, but we know that peripheral and central insulin resistance are prevalent in Parkinson's disease and, by the way, also in Alzheimer's disease. There are animal models that support a role of insulin resistance in brain diseases. And I show you how treatment with diabetic medication, and particularly GLP-1 agonists, are not only safe, but they show effectiveness in control studies that have been using 4 different drugs: exenatide, liraglutide, lixisenatide, and NLY-01, with important potential beneficial effect in motor, non-motor, and quality of life symptoms. And I just want to thank my team at Cedars-Sinai. We now have 5 movement disorder specialists, in addition to Dr. Samsky, that also, of course, is part of our Cedars-Sinai neurology department, that can take care, best care of our Parkinson community in Los Angeles. Thank you for your attention. If there are any questions, I'll be more than glad to answer if there is any time.
Thank you so much, Michele. When you're referring to the diabetes, are you referring to type 1 or type 2? And is pre-diabetes even real?
So we're referring mainly to type 2 diabetes. Type 1 is a genetic driven diabetes that is usually occur in younger people, in which for a number of reasons the pancreas cells that are in charge of producing insulin fail. But we refer to type 2 diabetes. And pre-diabetes is definitely real. I'm not sure where the question come from. Pre-diabetes is defined as a condition in which the glucose metabolism is clearly failing and can be diagnosed with an hemoglobin A1C. And when the hemoglobin A1C percentage is between 5.7 and 6.3%, that is considered pre-diabetes. When the percentage goes above 6.3, that is considered diabetes. And as I said earlier, the difference between pre-diabetes and diabetes is that pre-diabetes is considered reversible, so it's an actionable condition, while once we cross the line into diabetes, even the best effort in terms of exercise and diet probably is gonna and unfortunately fail, and only medication can improve the situation.
Thank you so much, Dr. Tagliati. This was incredible. We really appreciate you serving on our advisory board and your time today. So on behalf of everybody here, I want to say thank you. And
thank you for having me.
Absolutely. Our programs and support groups are all free to the community. PCLA increasingly relies on donations of individuals like you to continue our work. Please make a donation at pcla.org. But if you want to go ahead and take a break, and we'll be back here in 5 minutes, or if you want to stick around, I'm going to pull my virtual background out here, and I'm going to run us through a little bit of movement and a posture and breathing exercise here. I want to talk in particular today about the thoracic spine. Parkinson's affects parts of our body that are just naturally difficult for us to access. Our posterior structures, our internal structures, the spine. So we've got to be on a continuing journey to kind of access that. So access those parts and gain control. What I'm going to ask you to do is sit up tall in your chair and move into what I have heard or called the no money stretch, which is probably the most aptly named stretch I've ever discovered. No money. What this does is it opens up our chest, and it allows us to kind of access our shoulder blades. So I'm just going to have you move your arms in and out. I was asked years ago by a woman who had Parkinson's what the most important part of her body was, and I didn't have an answer for her. But over the years, I've come to decide that ground zero, or the most important part of your body, is the area directly behind your chest, on your back, when your shoulder blades are together and down, because it fixes so much out here with your posture. The way we live as a society encourages shallow breathing, and we'll just do a quick demonstration of that. Imagine we're sitting at our computer and we're typing, okay? We all do this, right? Let's exaggerate it a little bit for the sake of demonstration. Let's turn our thumbs down. And I want you to take a big breath in through the nose. And then exhale. Observe that. Let's do that one more time. And exhale. Now let's pull those arms back, externally rotate them, and back into the no money stretch. And now let's take a big breath into the nose. It goes on forever. Maintaining proper posture is so important for oxygenation of the blood, for posture. So we want to, again, be able to understand how to place ourselves and understand the function of the thoracic spine, where we get so much rotation and movement for our activities of daily living. So as we sit here, I want you to kind of visualize your spine. And we're going to go through some different movements here. We're going to take our hands, we're going to bring them forward, and we're going to turn all the way to the right. And then all the way back across to the left. A lot of this movement is coming from the thoracic. So we can rotate to the side and rotate to the side, right? We can also flex or side bend to the side. We can turn to the side here. And again, this is all thoracic, to the side here, back up. And as we're mobilizing, come back to center each time. We can also bend forward or flex forward around our forearms, right? This is, again, movement from the spine. We could flex forward and rotate. Follow that hand down and bring it up. Follow that hand down and bring it back up. So we could also arch back and go into extension. I like to call this the parachute movement. We've all seen people jumping out of planes and they're smiling, they got the goggles and the cheeks are going like that. We could go into extension, which is so important for Parkinson's, being able to maintain the ability to go to an extension. And we could go into extension with rotation. So it's like turn and arch back here and arch back. And we're going to do this one more time through all the different movements. We're going to turn to the right. And again, draw your attention to the spine, turn to the left, back to center. We could side bend here, side bend here. We could bend forward. These are all the things our spine does for us. We don't think about it. We could bend forward and turn. Flexion with rotation. We can go into the parachute, jump out of the plane with me. Arching back into extension, and we can extend and rotate back here and back here. And we're going to draw our hands back and externally rotate into a tall posture. And I want you to speak silently or think with me these words: I am certain, I am centered, and I am strong. Now what I want you to do is droop a little bit, slump. And I want you to say those same words. I am certain, I am centered, and I am strong. I can't even finish it. It doesn't make sense. Come on back here. You're strong. I am certain, I am centered, and I am strong. That's convincing. Face your issues with the day with tall posture. You'll win the war. All right. That's all I got for you. Just a little bit of that. Remember, place yourself, return to that nice open posture. The no money is a great cue for that. Keep seeking out understanding of the spine and that ground zero area directly between your shoulder blades when your shoulder blades are together and tucked down into your pockets. Big breath in and exhale. Thank you all for any of you who have clicked the donate button. We really appreciate it. Okay, our next segment is exercise with Ping Pong for Good. Now let's move our bodies a bit. We know that exercise is medicine. Trent MacLean and Maureen McCumsey, the founders of Ping Pong for Good, are going to lead us through some exercises for Parkinson's. Welcome, Trent and Maureen.
Hello.
Hey, Patrick. Thanks for that invigorating break.
Yes, I would love to have that introduction every time right before I have to present. It was a perfect thing to have. So thank you, Patrick. And thank you to the wonderful team at PCLA for hosting this event, and to this extraordinary medical advisory board who's presenting such valuable and important information here today. We're really excited to share with you some information about the health benefits of all things ping pong. And we're also excited to get you moving a little bit here real soon, which Trent's going to lead us through some of the exercises from our program. But before we do that, I'm going to tell you a little bit about Ping Pong for Good. During the last couple of years, we have been developing an exercise program that utilizes the unique properties of ping pong to create a workout that's good for the brain, the body, and the mood. We designed this program to promote healthy aging overall, while helping to hopefully slow the progression and reduce the symptoms associated with Parkinson's and other movement disorders. And it's also meant to be fun, and it's rare that we don't see a lot of smiles and laughter in our sessions. And one of the things that we've also realized about ping pong is that one of its rare aspects is that it's something that you can get significantly better at, even when you're getting older or you're confronted with something like Parkinson's. So we are so excited about the impact that this program can have. Now, our science-based program was developed with a cross-functional team of experts that include in neurology, physical therapy, and fitness. And the other key element of our program was that it was developed alongside a person living with Parkinson's, my co-founder, Trent MacLean, who you'll be hearing from in just a moment, and who will be, as I said before, walking us through some of our exercises. Now, there's growing research about the benefits of playing ping pong, which is very exciting to see, and we don't think is very commonly known. So We just recently participated in the Table Tennis World Health Congress, which brought together experts around the world focusing on the health benefits of table tennis and also looking to bring together research in this area. And we're excited and intend to be part of this research body of work. And in fact, in Q1 2024, we'll be conducting a feasibility study. And we're really honored to have Dr. Petrosian and Ryan Glad, who are Dr. Petrosian being on this advisory board as well as ours, and part of as we enter into this next phase. If you're in LA and you wanted information about participating, please let us know. So now, what is a ping pong fitness class? I'll just give you a quick overview. It begins with a full body warm up, so we can get our bodies and our minds ready for movement. Then we do a series of hand-eye coordination drills with just a paddle and a ball, which Trent will be demonstrating shortly. And then during class, we'll move into a series of table tennis drills. And these are meant to be, they're taught to be done cooperatively and can be adapted based on the participant's needs and the skill level. One of the core things that we work on is how do we adapt the various moves that we do in table tennis so that someone can do it seated or if they are challenged with balance. And one of the key elements that I think people experience when they're doing table tennis is how quickly they can improve. People who have never played the game or think they don't have any hand-eye coordination are able to participate and thrive. And finally, we end our sessions with gameplay. And that's for the fun factor, but also for that dopamine hit that we know that competition can generate. We currently have classes in Los Angeles, as well as in outside of Chicago and in Vancouver. We are hard at work working on our train-the-trainer program, which will be launching in January 2024, so we can make this program widely available in more communities. In the meantime, you can find some tutorials for some of the drills you'll be seeing here next, and now we can finally get moving because I know we've all been sitting all morning. And you can also find them on our website and on our YouTube channel. And now I'm going to hand it over to Trent.
Thanks, Mo. That was great. Patrick, always good to see you, and love your workout programs. Just as we usually do, we kind of do our share our story. And my story is kind of a long one, but it'll be abbreviated today. I was diagnosed about 13 years ago, but actually showed symptoms over 40 years ago. And I've kind of had a tough time physically over the years and been challenged. So I think that's why I kind of rolled with the diagnosis. You know, I kind of woke up with through life having the three main challenges on my body of the brain, the lungs, and the heart. And I was born with asthma, so that started with the lungs, then had an arrhythmia, which was dealt with an ablation about 14 years ago. And then finally, after all these symptoms, which I'd had for over 40 years, I was relieved to finally find out what was happening inside my body. And that was PD, of course. I've been very fortunate, though. My meds have not increased over the last 13 years. And I really owe my slow progression to an intense lifestyle and exercise program over those years. And a couple of years ago, I got a call from Maureen, and she told me about what was going on with her interest in table tennis and Parkinson's and some of the research that was going on. So it's when I decided to go public with my disease. And I went from mentoring one-on-one situations to mentoring, the groups that we have in our sessions. And I have to say, this, first of all, has become a key component of my workout program, where, of course, it's recommended that you complement it with weight resistance and cardio, which I do. But it's become sort of the cognitive piece, as well as for balance, mobility. So as well, the other thing that's motivated me now is, imagine when you've been with people you work with in a session over a 3, 4, 5 month period, some of them now for over a year, and they come to you and they say, this is our most favorite activity of the week. This is what we look forward to every week. And then the real clincher is table tennis has changed my life. And this is the point where I kind of stop being able to speak, in sentences, because it's kind of overwhelming. I say, you're serious about that? It's changed your life? And they say, absolutely, it's changed my life. And part of that component is not just about sort of the general well-being, because our focus is more on quality of life than seeking the cure. But on quality of life for these people, it's definitely made a difference for them, as it has for me. And the other thing it is, before I get up with the ball, is it's really created this kind of informal support group, and it's kind of cultivated this sense of community, which we never really planned on, and it's really been a bonus. So I'm going to stand up right now, and Patrick will probably be able to critique it. This is just a small sampling just to prepare you for what we're going to be doing with the racket and the ball, and hopefully some of you have been able to secure a racket and a ball for this. But the first thing we do is we warm up the wrists, the fingers, the forearms, because what we're preparing ourselves for day to day is usually, for Parkinson's in particular, and for me on my affected side, is kind of can get you pretty cramped up. And as Patrick was alluding to, you can been on the keyboard for a long time, you spend a day in the office, then you come to one of our sessions. We want to warm that up. And so we go one direction and then we reverse it. And depending on your flexibility or whether you've broken your wrist 3 times on this side, it may look a little different than mine does. And that's the other thing we do is when we work with people, we look at their physical limitations, whether it relates to age, lack of flexibility, injuries, or PD, and on the affected side. And the other thing we do is we're just going to take the fingers here and gently pull them back on the left side and just hold it there in place. And then reverse hands, same thing on the other side, just gently pulling back there so you can feel that stretch through the forearm and in the wrist. Then going back to the other side, on the outside of the hand, pull the fingers back, same thing, but be a lot more gentle on this side, because you can, if you overextend that can cause you more damage than good. So just gently tugging back on the fingers on this side, reverse to the other side, same thing. Arms straight as you do that. And then we just shake that out, and we've got the hands and fingers and wrists and forearms ready to hold the paddle and the ball. And let's, for those of you who don't have any sort of balance or dizziness issues, we can just do a light shoulder roll, head roll around. And if you're prone to having balance or some dizziness issues, maybe just a side to side or a yes, no would be good enough on the head and the shoulders. And for those of you who are feeling a little more balanced, a full head roll. Now let's just do the hips in one direction. I never remember whether I'm standing, whether it's clockwise looking down or looking straight ahead. So we just decide to go in one direction. And you should feel this through the hips, all the way down to the legs, into the ankles, with feet firmly planted, but you're really loosening everything up from shoulders down to ankles. And then reverse direction. This is obviously an abbreviated version of what we normally do, but it's just to get you ready for part 2 of our section. And then as a salute to kind of the big evolution in this, is we'll do one with left foot forward, arms up, and just greet the day. And again, to Patrick's point in this, when I do this and my chest is open, you can actually read the logo on my shirt. When my posture isn't as good, people usually will point that out to me. And a couple more. I was in physiotherapy the other day, and just to share this with you, they just thought, are you really stretching? Are you really opening yourself up? I want to hear you growl like a tiger. And all of a sudden I went, and I kind of woke up myself, but I woke up the whole PT studio. Now, hopefully didn't have your volume on too loud. For any of you who have a ping pong ball with you, bring it out now. If you don't have a ping pong ball, take any other type of ball or something you could put in your hand. Now, the thing that happens when we bring people into our programs is you've got, of course, in the Parkinson's situation, my affected side, my dominant side, and my non-dominant side. In my case, I have a double whammy because I'm left-handed with my dominant side, but my affected side is my right side. And it's also my non-dominant side. However, in table tennis, I need to toss the ball with my non-dominant side. So what we do is we start people off in their dominant hand and just with a small toss at first. And what we're doing here right now is, in terms of hand-eye coordination, is starting to kick in. Peripheral vision is starting to kick in, both, as you know, issues with PD. And if you looked at me now, you'd say, well, maybe that posture is not so good, and it probably isn't. So get those feet about shoulder width apart, because everything you're executing here above the waist is based on balance below the waist. So your core is engaged and your posture is attended to. Now, this may all seem quite easy at this point, and you increase the toss, and you do it with control in front of your body. As soon as you start to lose control and you're a little ways away from your center, you'll notice maybe one of your heels comes up and your balance is a little bit off. And everything we do in terms of our exercises and drills is Parkinson's approved, and means it's Parkinson's safe. Because for us, it's safety first, followed by effectiveness, and then followed by execution. So once you get comfortable on that dominant hand, you can toss it even higher. And the other thing, as most of you know, for Parkinson's, it's important for consistency that repetitive drills, closed drills in table tennis, are executed where particular things need to be re-automated. Now, watch now as I go to flip over to your other hand, which is either your non-dominant or affected side, and try and execute that same toss in front. This is the toss now that I have to use when I'm in competition, and I'm supposed to be able to toss it 6 inches straight up. For me, just to do that with my affected side is a challenge, and I've been doing this for a long time. And even to grip the ball. So again, our test with people is to know that they can keep it centered and they can toss it consistently at the same height. Now what we do is we start to go from hand to hand, because the other thing we're trying to do, and we're doing as an objective, is symmetry. And we're challenging our affected side to be able to replicate what the dominant and non-affected side is in my case. And that could be in terms of coordination, it could be in terms of strength, or it could be in terms of mobility. So there's a lot happening here. There's focus, there's attention over time, there's balance, and consistency. All this is happening just with the ball is worth about 4 or 5 cents. So, and this we encourage people to do at least twice a week. If they come to a class once a week, we encourage them to be doing this at home and to be able to start to have that symmetry. Imagine if you looked at a tennis player and you looked at his playing arm versus his non-playing arm, which could in some cases be almost twice in circumference. So we're trying to balance that out, because we have, as I said, the double whammy with non-dominant side as well as affected side, which again for you could be different. Now, when we introduce the racket to the scene, first thing we're going to do is we're going to hold it on the forehand side up. And if you have a typical racket, you have a black and a red side, black side being for the backhand. So take your dominant hand, in my case, the left hand, and have it face up for the forehand, and place the ball in the center in front of you, just as we would with the ball. And the idea here is this is probably your most confident position, and be able to balance the ball in the center in front of you. Again, same as it was in terms of tossing. Once you start to lose control of it, you're going to lose your core, lose your balance. So we start people here, and if that's even too much of a challenge at that point, we put the fingers over the ball, and we call it the cage, and give someone an easier start. And as Maureen said earlier, if this is too tough on balance, they can start in a seated position to do that first. But we're starting here with a static balance on the ball. And then once you get confident with that, take your buddy for a walk around your racket, let them do a 360 on the racket. And then you can start to get more comfortable. The other good reason for doing this is when you're playing the game, you should have your eye on the ball the entire time, and you should have your eye on the ball right to the point where it makes contact with the racket. Now, in terms of dynamic in here, if you have confidence here, both terms of the balance and being able to keep the ball in position, you could go as if I was going to my forehand side, take a step to the left, take a step to the right, forward. We tend to do fewer things backwards, obviously with Parkinson's, for a number of people that have issues with going backwards. So most of the drills are oriented to the left, some to the front and the side. If you're feeling really good one day, you can go, and if you don't have any issues with dizziness, you can do a 360 with it. The next thing we do is flip over to the backhand. And this, for most people, is a lot more challenging because, as you notice in our first warm-up exercise, where we got the wrist rolling, or pronation and supination, I have a bit of a problem with my dominant side because I broke this wrist 3 times and I just don't have that flexibility. So one of the things we do, because we are in the Parkinson's business, is we look at adaptations for everyone, whether it's based on something you were born with, something that may be injury related, or something that's PD related. Could be an off time. Yeah, and if we then we go to the bouncing side of it. And this one gets to be a lot more challenging. So again, we go forehand, backhand, and same we do static and dynamic. And then we're going forehand to backhand.
Wow.
And, you know, eventually here, there's a lot you can do in terms of progression. So the beauty of this is you start off very simple. Everyone's going to be successful. We don't want them to fail, but we have a tremendous number of progressions we can do that take you to a continued challenge. And as we know, we need intensity, we need variety, and we can offer that all.
And you can find, and we can find those drills, obviously, as we mentioned, on our website and our YouTube channel, and we're happy, feel free to reach out. Again, thank you for having us, Patrick, and hope the rest of the conference is as good as it's been so far. I mean, I know it's going to be amazing. Thank you.
This is so great. I mean, you can see immediately how good this is for people with Parkinson's. I mean, it's eye tracking, it's fine motor, it's muscle force regulation. Trent, great demonstration. Love it. Love it. Love it. Thank you for joining us today. Really appreciate it.
Pleasure. Thanks for your time.
Thank you.
Have a great rest of the day.
We don't talk about ping pong enough in my.
Oh, we will.
Okay. All right. In addition to the clickable links to donate on the chat there, PCLA is so proud to have been chosen to represent the Parkinson's community as the official charity of the Los Angeles Big 5K Marathon, which is happening March 16th in 2024. So visit PCLA.org to find out how you can join or create a team. It's a fun event to help you get in shape and help PCLA. It brings the community together. Take a look at it and consider joining us at PCLA.org. Our next topic is living as a woman with Parkinson's. Dr. Adrienne Keener is a board-certified neurologist and movement disorder specialist at UCLA and the West Los Angeles VA PADREC, which is Parkinson's Disease Research, Education, and Clinic Center. Dr. Keener participates in clinical research, patient care, and is interested in interdisciplinary treatment approaches for movement disorders, including deep brain stimulation, botulinum toxin injection, and rehabilitation therapies. Thank you, Adrienne, for being here today.
Yeah, wonderful to be here today to discuss this important topic. And I think, well, we'll be talking about what it's like to be a woman living with Parkinson's. I think that I will convince you that by addressing some of these women-specific issues, we can actually improve care for everyone living with Parkinson's disease. So we're all very well acquainted with Parkinson's disease. It's increasingly common with projected incidence that will be going up as we enter the future. But one thing that we also talk about when we talk about Parkinson's is that there happens to be a lower risk of Parkinson's disease in women compared to men. Estimates range from anywhere from 1.5 to 2 times more common in men. And just a quick definition of terms and distinction here as we enter this topic of women with Parkinson's disease. When we talk about sex, we're really talking about a biological characterization. And when we talk about gender, this is more of a social construction. So just wanted to make that distinction because both sex and gender can have an impact on how somebody lives with Parkinson's disease. So why is the risk lower in women? Well, we know that Parkinson's disease is due to a combination of your biology, genetic factors, hormonal factors, as well as certain environmental triggers or exposures. And so we may see that in women, there are different environmental as well as biological factors that impact their risk for developing Parkinson's disease. When we think about the environmental side of the coin, we know that women, for example, are less likely to be exposed to certain pesticides or heavy metals through their occupation compared to men, and also less likely to sustain a significant head injury, which can also be a risk factor for developing Parkinson's disease. On the biological side of the spectrum, hormones are one of the most obvious targets when we think about differential risk between the sexes. But there are likely other biologic differences between men and women that also contribute to this different risk of developing Parkinson's. Let's talk about estrogen. So we know in preclinical models of Parkinson's disease that male mice have different responses compared to female mice in certain preclinical models of Parkinson's. We also see under the microscope that estrogen can have an anti-inflammatory and potentially neuroprotective effect in the brain, and specifically may inhibit alpha-synuclein, which is the protein that clumps up, forming those Lewy bodies that we see in the brains of people with Parkinson's. Furthermore, we also see in epidemiologic studies that estrogen exposure may impact Parkinson's risk. So here at UCLA, with colleagues of mine, we are part of a Parkinson's gene and environment study that has shown that increased menopausal age, so longer duration of estrogen exposure throughout the lifetime, can decrease the risk of developing Parkinson's disease. Other studies have also shown that the timing and duration of hormone exposure may be critical. So, for example, if you're taking hormone replacement therapy after menopause, the timing of that estrogen exposure may have a different effect on your risk for developing Parkinson's disease. We also know that estrogen may modulate other risk factors that have been identified in Parkinson's disease. For example, studies have shown that caffeine consumption is linked to a lower risk of Parkinson's disease among men, but not among women. We've also seen that non-aspirin NSAID use is associated with a lower risk of PD in men, but actually a higher risk of PD among women. And finally, urate lowering medications have also been shown to decrease Parkinson's disease risk. This has only been demonstrated in men as well as in postmenopausal women where urate levels are more similar to those of men. So we know that these biological factors inherent to women are probably contributing to their lower risk of developing Parkinson's disease. We also know that once you develop Parkinson's disease, men and women experience the disease very differently. And this ranges from their symptoms, non-motor and motor symptoms, their experience with treatments, as well as their access to specialized care for Parkinson's disease. As Parkinson's disease progresses, we know that the constellation of motor and non-motor symptoms continues to grow. And I just want to take this moment to emphasize that non-motor symptoms in particular can have a significant impact on a person's quality of life living with Parkinson's disease. And these are often those symptoms that are under the surface or not visible. And so these symptoms are really important to talk about. And we see different non-motor symptom burden between men and women living with Parkinson's disease. For example, we know that Parkinson's disease typically has a slightly earlier age of onset in men compared to women. We also see that in terms of the motor symptoms, women more often have tremor-dominant Parkinson's disease. They're also more likely to develop motor fluctuations and dyskinesias with Parkinson's disease. When we look at non-motor symptom burden, we see that certain non-motor symptoms are more common in women compared to men. These include pain, depression, anxiety, and fatigue. We also know that different non-motor symptoms have an impact on quality of life for men and women. Depression and fatigue have been shown to be the most impactful for women living with Parkinson's disease, whereas cognitive changes tend to have a greater impact on quality of life for men living with Parkinson's disease. We also know that these symptoms can fluctuate uniquely in women in relationship to their hormonal status. For example, around the time of the menstrual cycle, many women report worsening of their Parkinson's symptoms. This has brought into the question whether or not we should adjust treatment around that time period to improve quality of life for women with Parkinson's disease. We also have seen that during pregnancy and the immediate postpartum period that Parkinson's symptoms can be exacerbated. And there's a relatively poor understanding of what treatments might be safe to use during pregnancy in patients with Parkinson's disease. Around the time of menopause and postmenopausal, we also see a change in symptoms with Parkinson's disease. And there's also very little data on appropriate use of hormone replacement therapy and how that may impact Parkinson's symptoms. Some studies have shown that treating postmenopausal women with Parkinson's disease can actually improve motor fluctuations, though as I mentioned earlier, the timing and type of that hormone therapy may have an impact on the overall disease. And so this is really an area where future research is needed to clarify and provide guidelines as to appropriate hormonal therapy in Parkinson's. We also know that women with Parkinson's disease have an increased risk of other comorbid medical conditions that really can be devastating, like hip fracture and osteoporosis. And so treating and addressing these non-Parkinson's related medical issues can really have a huge impact on quality of life for women living with Parkinson's disease. We also know that women respond differently to treatment for Parkinson's disease. I mentioned earlier, they're more likely to develop dyskinesias or motor fluctuations in the course of their disease. And we also know that there may be different genetic determinants that contribute to this, as well as different drug metabolism that may contribute to their response to medications. There's also been very well-documented disparities in utilization of advanced therapies like deep brain stimulation in Parkinson's disease. So women are less likely to receive DBS for treatment of their Parkinson's disease. However, some studies have shown that women who do get DBS actually report greater gains in their quality of life compared to men. So this is a therapy that certainly has at least equivalent benefit for men and women with Parkinson's, but for some reason, women are not accessing this therapy as often as men. Why is this the case? There are probably several different factors, including barriers in access to care, perhaps patient preferences or a perceived risk of some of these more advanced therapies like DBS. It's also possible that there are biases among healthcare providers and physicians that impact the way women and men are treated. Also, other health conditions or comorbidities that differ between men and women. And finally, there are no specific studies looking at things like drug safety, metabolism, tolerance, specifically in women with Parkinson's disease. And the majority of research studies are actually comprised of men. And so this is not something that's specifically studied in women. We also see that women are much less likely than men to see a neurologist for their Parkinson's care, though we know that being under a neurologist care is associated with improved outcomes. For example, people treated by neurologists are more likely to access rehabilitation therapies, and we've just been learning about the importance of those. We also know that they're less likely to be placed in a skilled nursing facility. They have a lower risk of hip fracture or hospitalization, and a lower likelihood of death. So being cared for by a neurologist really can improve your quality of life with Parkinson's disease. And for some reason, we see that women are not getting this specialized care. Part of the reason is that we see a significant delay in diagnosis and referral to a specialist in women with Parkinson's disease. So you can see here from this wonderful paper women on the top compared to men on the bottom. From the time of their onset of Parkinson's symptoms, it takes them longer to bring that to the attention of their physician. And even from the time they see the physician, it takes longer for them to receive a diagnosis of Parkinson's disease. And even once diagnosed, there's an even longer delay for referral to a movement disorder specialist for their care. And so addressing these delays in care and disparities in treatment can really have a positive impact on your quality of life if you're a woman living with Parkinson's disease. One of the reasons that there may be some of these disparities is that the image that we have in our minds from the time that we're medical students learning about Parkinson's disease is an image of an older man. And this was a wonderful editorial published by Mike Oken and his colleague a few years ago, arguing that it's time for a new image of Parkinson's disease. Young people can get Parkinson's disease, women can get Parkinson's disease, our non-white patients can get Parkinson's disease. And so part of the delays in diagnosis may stem from the fact that as medical providers, we are educated male person getting Parkinson's disease. And so I also want to give credit to the many women living with Parkinson's disease who have been public about their diagnosis and advocating bringing that image to life for us. We also see differences in long-term care for women with Parkinson's disease. We know that they're more likely to be placed in a skilled nursing facility. They're also more likely to need to pay non-relatives for care and less likely to be accompanied to their office visits. They're more likely to live alone. And so we think about the treatment trajectory and the care trajectory for our women living with Parkinson's disease. We have to think about the support system that they have around them and how we can improve that. This word cloud here was from a recent paper published just this year looking at the gendered experience of patients with Parkinson's disease and showing that we know that gender norms and stereotypes can influence the illness experience. For example, women reported that they often see themselves in a caregiving role for others. And studies have shown that when in this role, women often neglect their own medical needs or health care. And so it's really important to think about the cultural and social context of our patients, not only women, but just thinking about what roles in society, what expectations from society are placed upon our patients and how that might impact their experience living with Parkinson's disease. This is a quote from another paper sort of highlighting this, which I really love. And this woman said, although I realize that getting the disease is not my fault, it did compromise my roles as a mother of a young child, the daughter of an elderly parent, a wife, and a business partner. So I think when treating all of our patients with Parkinson's disease, not just women, we really need to think about how having the disease may impact their self-image, their perception, as well as the perception of others around them and their roles in their families, in their jobs, and in society at large. So now that we know this information, what can we do about it? I was asked to provide just 3 take-home messages in these 15 minutes, and I struggled to cut it down to 3. So I'll leave you with little more than 3. But I think those of you who are here are already taking the first steps to address some of these barriers. So getting educated and having this knowledge can empower you to advocate for yourself, advocate for your loved one with Parkinson's disease. I think we need to, as a field, improve access to subspecialty care. We know there are not enough movement disorder specialists to go around. And so both from improving access through modalities like telemedicine, reaching people who don't have access to subspecialists, and training future movement disorder subspecialists to provide more care to meet the demands. I think it's also important to advocate for customized treatment. And for women, this means paying attention to things like their hormonal cycles and life stages, drug metabolism differences, and really a need to develop guidance around management of the disease through pregnancy, hormone replacement therapy around menopause. I think also paying attention to comorbidities that disproportionately affect women, like osteoporosis, pelvic floor dysfunction, weight loss, and the impact that that can have on quality of life with Parkinson's disease. Finally, I think for all of our patients, it's important to provide that culturally sensitive care, understanding how their self-image, their relationships, their role in society impacts their experience living with Parkinson's disease. And finally, for everyone, I would just say to make yourself a priority, but especially for those women who are used to playing the caregiving role for others, take a moment for self-care. Make sure you have social support, an advocate, someone to help you through this disease. And also really pay attention to making those long-term care plans, especially for women who might be single. We know that they are really in need of more long-term care assistance. And lastly, I would say improving engagement in research and advocacy is another important thing that we could do. We know that women are underrepresented in clinical trials for Parkinson's disease. And so if it is something that interests you, I'd encourage you to get involved in research as well as advocacy. So I will end my presentation there and leave hopefully a few minutes for questions at the end of this half hour.
That's wonderful. Thank you so much. And to give PCLA a plug, we do have a Women with Parkinson's support group that we are running. Judy, do you want to say anything about that?
Yes, we actually have 2 women support groups. So Angela Neff, one of our board members, runs one group, and I think Juanita also is doing a group. So we are constantly trying to meet the needs of our community. And we thank you all for joining us today.
Absolutely. Okay, so we've got some questions here. Is there any study on the effect of cinnamon on women that is different from men? I meant combination of levodopa, carbidopa, any brands. Thank you.
Yeah, so I don't know of any specific studies looking at different brands or manufacturers of carbidopa, levodopa, but there are several studies looking at the metabolism and pharmacokinetics of levodopa, and it is in fact different in women compared to men, which is probably partly why women are more likely to develop dyskinesias. The original studies on levodopa were primarily done in men. And so certainly, I think paying attention to the dosing of medications and understanding that the same dose of levodopa in a woman is going to be metabolized very differently than in a man. And so yes, there are several studies actually that have looked at this effect.
How differently would a movement disorder specialist diagnose or prescribe than a neurologist?
Yeah, so I think there are studies that show that movement disorders specialists tend to provide higher quality of care for Parkinson's disease, and I think part of that is because we as specialists spend all of our time learning, staying up to date with the latest treatments and guidelines for Parkinson's, and treating many, many, many more patients with Parkinson's disease compared to a general neurologist who also treats patients with migraines and back pain and other neurologic disorders. And so I think, we just have, I think, a greater fund of knowledge and are sort of staying more up to date with the latest research for Parkinson's compared to a general neurologist. So I would really encourage everyone, if you can get access to a movement disorder specialist, even just for a consultation to go alongside your general neurologist's care, I think it would be to your advantage.
I know geographical issues can prevent people from seeing an MDS. What is the current state of things in terms of virtual appointments?
Yeah. So during the pandemic, telemedicine was really opened very broadly up across the country. More recently, however, some of those restrictions have come back into place, and so you have to be within the same state. And that's actually sort of unfortunate because in some states, there is only 1 or 2 movement disorder specialists for an entire state. I would say here in Los Angeles, we're fortunate to have so many movement disorder specialists, but I think even we find our wait lists are so long because the demand is so high. But yeah, telemedicine, certainly through my role in the VA, where we can treat patients nationally, has really been a wonderful way for people who might live more rurally without access to a specialist to be able to meet with us and receive care.
Thank you so much, Adrienne. This is just fabulous. And I like to think that this environment here gives folks an opportunity to meet such talented people like yourself and the rest of our advisory board. So thank you for joining us today. Really appreciate it.
My pleasure. Thanks for having me.
So our next topic is navigating communications with Parkinson's. Dr. Melita Petrosian is a fellowship-trained neurologist and movement disorder specialist and is the director of the Pacific Movement Disorders Center located at Providence St. John's Health Center and Providence Little Company of Mary Medical Center, Torrance. Melita is our most recent addition to PCLA's Medical Advisory Board, and we feel so fortunate to have her with us. Please welcome Melita Petrosian.
Thank you for having me. I appreciate the work everybody's done to put this conference together. Today I'm going to be talking about communication issues with Parkinson's. And we're going to talk about some challenges people might experience, cognitive changes that can occur, and some coping strategies. They will be intermixed as the slides go forward. Please note that not all patients will experience any or all of these symptoms either now or in the future. So I like to give the autopilot analogy when discussing what Parkinson's is, how the part of the brain that controls the automatic or subconscious movements can be affected. For example, from a motor perspective, shuffling or reduced arm swing. But these things also occur in speech as well as in cognitive function as well, that there is an autopilot of our voice controlling the volume of our voice and an autopilot in our brain really controlling the flow of our thoughts. So interestingly, the physical or motor limitations, specifically in this case, referring to the power of the voice, can contribute to or be interrelated with cognitive or thinking obstacles. And all of that is very much tied into the emotional state, whether somebody's experiencing stress, either externally or internally, experiencing anxiety or depression. And the arrows really go every which way with this. I wanted to start with discussing some of the cognitive challenges that people can experience, especially in the voice, affecting the volume of the voice, the clarity of the voice. The tempo of the voice can either go fast or slow, actually. Facial expressivity can affect, and other aspects of body language can affect communication because, of course, part of communication is nonverbal. So the listener may, or the conversation partner may misinterpret a flatter affect as disinterest or apathy. Thinking obstacles can affect, for example, the clarity of the words coming through. But of course, fatigue is a common symptom of Parkinson's that can impact the quality of the conversation, especially in an event where there's a lot of people talking at once. One's self-image can also affect how that conversation goes, or the tendency for the person with Parkinson's to speak up versus to stay more silent in a group conversation. And then many people feel more comfortable speaking with somebody that they know compared to speaking with unknown people. And as mentioned before, their emotional state and mindset play a large role. And then frankly, communication is a two-way street. So the hearing issues that can occur in people who are, in that family or in that diet of the person with Parkinson's can be part of the issue with communication challenges as well. If the other person isn't hearing the softer voice, for example, that can of course be a source of disagreement between the person who may not believe that their voice is the problem and the person who may not believe their hearing is the problem, or vice versa. So some coping techniques that people with Parkinson's and their care partners or family members can bear in mind include just paying more attention to their voice or thinking about speaking up, thinking about using their diaphragm and projecting the way an actor or a news presenter might. As far as the nonverbal communication and facial expressivity, The care partner or conversation partner might use the power of mirroring to sort of smile more broadly or introduce other emotional components and allow that mirror neurons in the Parkinson's brain to sort of light up a little bit more there. Often rehearsal and practice can be important. For example, if an important phone conversation needs to be had, having really a bullet point or an outline of what the key words are that one is trying to get across can be very helpful. Keeping it short for the, oh, I realized I wrote that twice, sorry about that. So taking a break, for example, allowing pauses. I have a rest sign there on the right there because, you know, sometimes people get uncomfortable with silence. And I find that it's okay to take a breath and let that person with Parkinson's find that word that they're looking for. But the family member may want to be helpful and try to get that word in that that person was trying to say, and that can be frustrating to the person with Parkinson's. And also it may not be the word that that person was thinking of, so now they've been derailed from their train of thought by this other word that got introduced that they weren't trying to say. So understanding the value and the power of rest, because without the rest, music doesn't make sense, and that's true in speech as well. So it is okay for the person with Parkinson's, if they're naturally speaking slower, for that conversation partner to sort of meet them where they are, or conversely, if the speech is becoming overly quick, for that person with Parkinson's to think about practicing slowing themselves down and speaking the words more clearly. So really important is speech therapy. I find this is very underutilized in my patients because unfortunately I actually see frequently people not valuing or necessarily you know, recognizing the importance of their voice issues in terms of thinking about the power and the importance of doing speech therapy. Of course, it does take time, especially the specific speech therapy that's been developed for Parkinson's, which is called Lee-Silverman voice therapy, or LSVT Loud. The traditional LSVT Loud program is 4 days a week, 4 weeks. So that's, you know, quite intensive, and there's homework involved. It doesn't work without the homework. Homework is really just the repetitive practice that allows for the gains to be carried over. And so I think this is something that more people ought to make use of. There are also other types of voice therapy for Parkinson's, such as Speak Out, which is through the Parkinson's Voice Project. That group also incorporates weekly online Parkinson's sing-alongs and the power of music in improving speech, but also in improving one's ability to sing, which a lot of people with Parkinson's are concerned about or have issues with. Music Men's Minds is another online and in-person singing group for people with Parkinson's, but also people with other neurodegenerative diseases, and that can be really powerful and helpful as well. EMST 150 is a way to improve what are called the expiratory muscles. So when we speak, it's always on exhalation, on the breath coming out, which we term expiration. So expiratory muscles are like the diaphragm and other muscles between the ribs that control how much breath we can bring out. A lot of people with Parkinson's, their voice starts to peter out and get soft, and then they can think about it again and get it loud again, but then it gets quiet again. So by improving the amount of breath that can be pushed out of the vocal cords by doing an expiratory muscle strength trainer technique, this actually can be really helpful, and it's been proven in clinical trials in Parkinson's patients that it can improve vocal loudness and what's called sustained phonation, meaning like how long can you talk in one breath without getting lost. It also has the additional side effects, as it were, of improving swallow function and cough strength, which is important for clearing things out. I like to call this the dumbbell for your diaphragm, the same way we know we need to do resistance training with, for example, Patrick and squats and sit to stand exercises. We need to do resistance training for our diaphragm. EMST 150 isn't the only device that's good for this, but it's one that has a lot of evidence behind it. However, the problem is it's not magic. It needs to be done by the person with Parkinson's. 5 breaths per set, 5 sets a day, 5 days a week. There's no medicine in it. It's really just breathing out against resistance, and there is a gauge to adjust the resistance to make it more difficult. So let's move on to cognitive changes. I want to reference a book that was written by a person with Parkinson's. Her name is Marina Nordgraf, and her illustrations are used in this presentation. So all of the drawings are from her, including the one from the previous slide. She collaborated with a neuropsychologist and a Parkinson's neurologist to create a book discussing some of the symptoms of Parkinson's patients, specifically thinking obstacles or cognitive changes. And a lot of people who are even in an earlier stage of Parkinson's can notice changes. It doesn't mean that they're unable to get things done cognitively, but it means that they may have to do things a little bit differently. Again, in the same way that they may need to be more mindful of how they're walking or how they're speaking, they may need to be more mindful of what their thought process are to get where they need to go. So I love this drawing. It's a really good kind of description of getting from start to finish isn't necessarily a straight line. It's not necessarily easy, maybe meander, but people can get there. The other reason why I love this analogy of a detour is that an obstacle is like a roadblock in somebody's journey. If they need to get home and there's a roadblock there, they're not going to just not go home. They're going to have to find a new way to get home. And that new way, that detour, might take longer, might be frustrating, might require some creativity, but they will get there in the end. And I think it's a way for people to feel more empowered that they can actualize the things they want to do. They just have to do things in a different way. The book is available through this website, but it's available also for free through as a PDF. So the book is set up with obstacles and different detour options, both for the person with Parkinson's as well as for their care partner, as well as some ideas for how to communicate the needs of the person with Parkinson's so that other people are more sensitive to these communication and other cognitive issues. So some of the things that are specific to communication include word finding difficulties. Of course, this happens to all of us, but it does happen more frequently or more frustratingly to the person with Parkinson's. It's, of course, that temporary inability to retrieve a word, and it can be coped with word substitution, but that is sort of somewhat of the problem itself. Many people express trouble with names. What was the name of that movie with that one guy from that one place? And so there's many ways to try to cope with this. As I mentioned earlier, sometimes it's important to prepare for important conversations. Sometimes it makes sense to actually try to visualize the object, if the word is, for example, a noun, to try to get to that word. A lot of times humor helps. Making a joke about it in the conversation helps sort of break that tension. Taking a breath to reset and sort of Control-Alt-Delete and start over with the beginning of that sentence can often help. There is a degree to which people need to accept the symptom rather than getting overly frustrated by it, because that emotional state matters with it. So just sort of framing it as, okay, I know this word will come back to me in a moment, but now I'm going to shift to another part of this conversation. Sometimes it's okay to Google it. We all do that. Oh, what was that, one name of that person? Oh, let's look it up. Oh, yeah, that's right. And again, as I said before, for the care partner, it's important for them to know, take a beat. Don't try to finish all their sentences. However, there may be times that the person with Parkinson's may, turn to the care partner and say, okay, I need your help finding that word. And that's okay if it's an agreement or something that's understood. Another common obstacle to free and easy communication is difficulty with filtering visual and auditory stimuli. For example, if there's a lot going on, and this can happen in larger cocktail parties where there's 3 conversations in the background, or the radio is playing and the dishwasher turns on, or the coffee grinder gets turned on, and that can make it difficult for the person with Parkinson's to focus on the task at hand. It can be difficult to sort of suppress that unnecessary stimulation, or stimuli rather. So ways to cope with that is perhaps having a gathering with a smaller group. If somebody's working on their own and they need to focus, they may want to wear noise canceling headphones. They may need to attend events for shorter periods of time, but they may need to communicate their needs to other people who are there. Could we please turn off the TV so I can focus on this conversation with you? Could you please talk one at a time so that I can follow in on this conversation? And what I love about these two images you see here is that they're actually physical cards that come with the book and can be printed and can be sort of handed out as this is what I need, self-advocacy. Like if we all kind of work together, I can continue to join in on this conversation rather than feeling withdrawn from the conversation. Many people have difficulty with multitasking, and that can also affect communication. So for example, if one person is focused on a task on their computer, answering an email, and then a family member comes into the room and says, what do you want for lunch? It may be very difficult for the person with Parkinson's to shift their attention away from what they were doing and then have that conversation and then come back to what they were doing. I like to say multitasking is an illusion. Really, people think that they can do multiple things at once, but in reality, we're really only able to consciously attend to one thing at a time. The other things we're doing subconsciously, utilizing our autopilot. And of course, that autopilot is affected in Parkinson's. And set shifting takes longer. It's more difficult to change gears. So we need to take things one step at a time. And that's true not only of the person with Parkinson's, but of the care partner as well, the family member. Wait for the person to finish before addressing the second task. Slow down and make sure that we're focusing on the more important task at hand. So when to call in for support, or when to think about, okay, I need more help with this, either as the person or the family member. Well, again, we talked about speech therapy. Bear in mind that speech therapists can also do a type of therapy called cognitive therapy, which can help improve cognitive function. Talking to the neurologist about, well, I've noticed they're having more difficulty with their speech when their medications are wearing off. Can we talk about adjusting their medications? Or noticing that the emotional state is really playing a big role. The anxiety is causing this person to really, out of proportion, freeze up on the phone. Can we talk about treatments for depression or anxiety? Do they need therapy? Do they need medications for depression or anxiety? Maybe they need to be seeing a therapist or a psychiatrist. The next speaker is going to be talking about intimacy. And I think that this dovetails nicely into that, because a lot of communication is about, goes both ways. And I find that sometimes I'm playing the role of the marital counselor between, the person and their spouse, in terms of, some of these things are universal to couples. Like many spouses don't listen to each other or pay attention to each other, even when there isn't Parkinson's at play. So that may be something that could be valuable to certain couples. Joining a support group, the care partner support groups can also be helpful. And then turning to spiritual or community support, as I mentioned, music and singing. And there are also a lot of benefits to be gained from mindful awareness, meditation, and there are, of course, memory classes and cognitive skill building apps that can be used as well. I won't spend too much time on this, but speech therapists can also recommend certain devices, like the Speech Vibe. Used to be a device, but now it's available as an app that you can link to your own headphones or earbuds. It works based off of this idea that when you're at a cocktail party, you have this kind of reflex to speak louder because there's background noise behind you. So the Speech Vibe app provides sort of this background noise that makes the person speak louder. And this sometimes only works when the app is ongoing, but it can be helpful. And some patients who are really having great difficulty with their voice might be using voice amplifier, might work with a speech therapist for delayed auditory feedback. So I was asked to give 3 takeaways. I think the big picture is really turn to a speech therapist and really, accept that referral if it's offered, or advocate and ask for that referral, because it can help. And then, finding the detours either for the person with Parkinson's or for the care partner, finding that creativity, and trying to sort of minimize the frustration by, accepting things and then looking for that detour and that way out can be very helpful. And take a breath. This has many meanings, right? So we talked about EMST and strengthening our breath, but also just take a beat, take a breath, mindful awareness. Really, all of these things do play a role in how we communicate on both ends of the person and the people who are affected by Parkinson's disease. So that's all I have, but I'm here for questions.
Wonderful. Thank you so much, Melita. This was awesome. So let's get on to some questions. How important is it to socialize for the person with Parkinson's, even though they may want to isolate?
Oh my gosh, what an amazing question. I'm going to reference Dr. Subramanian, whom I know many of you know, and her study on social isolation affecting, or being associated with reduced quality of life in people with Parkinson's disease. It's huge. I absolutely emphasize this. But as I said, I think that sometimes it's an adjustment. Sometimes if people are noticing that their family member or loved one is not really doing well in a larger gathering, sometimes it's about having a, go out to lunch with one other couple, or, get on the phone and have a conversation. But I think it's very important to keep at it. And partly because, when it's like, if you don't use it, you lose it. Sometimes some of my patients, the only person they talk to all day is their spouse. And, they may not be having actually a conversation about something fun or meaningful. They might be talking about, hey, did you take your pill? And hey, you got to exercise, So it's nice to, kind of flex that muscle of talking about things that are fun, talking about, music and movies and things like that. And again, I really appreciate the work that PCLA does to try to really emphasize the social network and the social aspect of managing Parkinson's.
So would you recommend a couples counselor that would know Parkinson's? Or, how does a couple that knows they need help find the help, and who would that person be?
Oh, that's a great question. Unfortunately, these days, it's been harder to find therapists. I think there's a lot of, excess demand for mental health specialists. But I did give a talk a while back to a group of, therapists and counselors. And I don't think we had a lot of marital counselors, but there are therapists who have experience with this. But to a certain extent, I do believe that it might be reasonable to have people, just frame it as, what do you recommend for couples completely ignoring the Parkinson's? What are those techniques that can be helpful? For example, making sure that somebody's available to hear that conversation. That's true for all couples. Or, framing things as the I sentences instead of you always or you never, the issues with, feeling blamed or feeling put down upon. I sense that would be true in any couple, or not any, but many couples. And I don't think that these things are limited to people with Parkinson's. But again, I'm interested to hear what Dr. Wertheimer will have to say about that, because I think it's relevant there too.
Can you elaborate a little bit on that? And I think what you're talking about is almost scripting your conversation and eliminating phrases like "you never" and replacing it with, is it "I feel" or?
Oh yeah, okay. You're asking a neurologist therapy question, so I'm not going to pretend to be. Like I said, I wear the hat of the marital counselor, but I'm actually not a marital counselor. But I believe it's that idea of, framing things in a kind way. I think appreciation, kindness, and actually being mindful of, the things that we love about our, loved ones actually helps. And that goes back to mindful awareness, that people can do kind of like breathing techniques of like, wait, let me, bring to mind the things that I like about this person and start from there. And that can help before getting into the conversation of, gosh, I would really like it if you would do blah, 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 or it would make it easier for me if you didn't interrupt me while when I was talking, something like that.
Okay. Sorry to put you on the spot like that, but does medication Exelon help with train of thought?
Oh, great question. Yes, short answer is it can. Exelon is rivastigmine. It's an acetylcholinesterase inhibitor, which means that it boosts acetylcholine in the brain. Now, a lot of people with Parkinson's think Parkinson's is all about dopamine loss or dopamine dysregulation, but there are other neurotransmitters that play a role, and acetylcholine is one that's more involved in those cognitive pathways. So yes, boosting acetylcholine can help with processing speed and coming up with words and staying on track with the train of thought. It doesn't help universally, and sometimes often the benefit is modest, to be honest, but it can help.
Okay. Patrice states hearing loss, which is more common with dementia and also with advanced age, can make all of this topic worse. So add an audiologist as one of your care team. Make sure hearing isn't worsening your symptoms.
Great feedback. Thank you. I neglected that member of the team. Absolutely. I did mention hearing, but yes, absolutely. Untreated hearing loss is associated with the subsequent increased risk of dementia. And partly that's because if somebody's not really hearing half of what's being said, then they're not participating in the conversation. And again, that's not even just a Parkinson's thing. But also it takes more cognitive effort to wait, what did they say? What were they saying? Because, things aren't being heard. And again, I have a lot of people who have tried hearing aids or who have complaints about hearing aids, but definitely working with an audiologist to find the best possible option. And then doing other things like, hey, let's turn off the background music. Let's meet in a quieter, restaurant, or let's meet at our home instead of at a loud, busy restaurant. Those are the kinds of things that can help.
And this is a follow-up. Are there other medications beyond Exelon to help with cognitive symptoms? It seems that there are so few.
Yes. So the only thing that's FDA approved for Parkinson's related cognitive decline is Exelon. Off-label, we also use donepezil, but that's in the same class. And there isn't as much evidence that Namenda, which is memantine, can help, but it's sometimes tried. There's really nothing else that's proven as far as specifically for cognitive. Interestingly, occasionally I have people who express to me that when they take their levodopa, they do feel sharper cognitively. That's certainly not the universal experience. It's not necessarily the expectation, but I have had some of my patients express that. And when people are experiencing off time where their medications are wearing off, often they can manifest with cognitive issues or speech issues as well. So again, as I said before, sometimes having that conversation. But yes, there are some clinical trials that are looking for better management, better treatments for cognitive function in people with Parkinson's and dementia with Lewy bodies.
What might be the first sign that there's something cognitively going on?
I think the patient themselves might feel that they are just a little bit slower to respond, processing speed. Or just a little bit of word finding. What was that word I meant, or what was that name of that one person? Names can be tricky. Those can be the first symptoms. But are you asking like where it's further along, or just at the very beginning?
Yeah, I guess I've heard people question themselves or maybe start to lose confidence because they feel like they might not have been as sharp, and they're maybe wondering if this is the Parkinson's or maybe something different. Or is there any type of opening symptoms that indicate that there might be some cognitive impairment?
Yeah, I do think that, as I said, processing speed, word finding, I think the time where you might sort of express concern would be, are things getting missed? Are they getting confused? Are they struggling with doing things they used to be able to do? Or, for example, new tasks get put in. A good example is technology, right? Like, the smartphone gets an update, and now, it's, everybody struggles with that. But is it like all of a sudden they can't figure out how to make a phone call, that kind of thing? But I would frame it as confidence, it's a really good word you used. And I think that it's important for people to accept where they're noticing a change, but also push themselves to figure out, but is this something I can still work around? Again, that idea of that detour. I have a roadblock, but I'm going to get there eventually. I just have to find a way through that, because a loss of confidence is a big, negative impact on the cognition and on the speech that, isn't necessarily a helpful thing, if that makes sense. Like, I think that, framing oneself as, hey, yes, I have this change in how I'm doing, but I still have, X, Y, or Z, my memory's good, or, I'm still able to get there in the end. I think having that improvement in, or sustaining their confidence is a really key part of that. So I would really frame this as, when people are reading about Parkinson's and the things that can happen, and it all feels very negative and down, don't sort of accept that as, okay, if this one time I forgot my keys, that was so embarrassing. Do not start thinking, oh, this is it, I have dementia now, because that's going to actually make things worse to have a negative mindset about it. And, I don't mean to be too Pollyanna-ish, but it does matter. It does matter. Mindset matters.
Okay, well, thank you so much. I think we'll close on that. No, that's awesome. Thank you for joining us, Melita. This was fantastic.
Thank you. Thank you for having me.
Sure. So our last topic is exploring intimacy with Parkinson's. Dr. Jeffrey Wertheimer will be speaking on the important and sometimes neglected topic of intimacy with Parkinson's. He is the Chief of Psychology and Neuropsychology at the Director of Clinical Training in Neuropsychology at Cedars-Sinai Medical Center and the California Rehab Institute. He has developed innovative programming for cognitive and psychological resilience for diverse medical populations. Please take it away, Jeffrey.
Thank you, Patrick. And I'll seize the moment now to say thank you, Judy, Patrick, and Vivian too, and the rest of the board for the opportunity. What great panelists. It's a privilege to be among them. So thank you for the opportunity to present today. All right, so first and foremost, Patrick, you had such a great segue in the front end. I mean, intimacy in Parkinson's is one ubiquitous. I mean, it applies to every one of us. The unfortunate part is it's one of the least discussed topics in Parkinson's and actually in most relationships today. So first off, let's put that in context. It's hugely important and we don't discuss it enough. So let's even start there. I'd like to highlight a few questions. This is rhetorical, just to make you guys think for a moment. How do you define intimacy? What does intimacy mean to you? And what does it mean to feel intimately connected, emotionally, intellectually, physically, and spiritually? So ponder for a moment. And with that, I've got 14 more minutes to pack in these objectives. So I'm going to go through this piece here. One, I want to define intimacy. I want to understand intimacy and sexuality as it relates to Parkinson's disease, interestingly, through a biopsychosocial model. That's actually very important to understanding intimacy for all of us, and in particular with Parkinson's patients. I want to introduce the importance of conversations about intimacy and sexuality. Dr. Petrosian, excellent commentary, great presentation as well. But there's elements of how we communicate and our approach to communication that is really going to be key to helping us create the safe space for such an important topic. We'll talk about how to deepen emotional intimacy, and then just a brief comments when we get to the conclusions about how do we access individuals who can help address intimacy and sexuality through the healthcare professions. So with that, let's define intimacy on the front end, just so we're all on the same page. It's the level of closeness you have with another with feelings of vulnerability, openness, and trust, okay? But when you think about it, now when I asked you, how do you define intimacy, what's the first thing that comes to mind? Oftentimes physical. That's where we tend to go when we think about intimacy with others. But I do want to create that space to say, let's broaden our definition. This is really imperative that we do that because this is our element of food for the soul, but also are engaging in our relationships at a deeper level with intellectual intimacy, emotional intimacy, spiritual intimacy, in addition to physical intimacy. And I'll elaborate on all of those very soon. With that, though, let's revisit why it's important. Yes, as a social species, of course, companionship is crucial, and companionship can take many forms through friends, through our relationship with a care partner, with our relationship with our spouse and other family members. But it's our ability to feel connected to another person and have a sense of belonging. In essence, we're trying to combat that feelings of loneliness because we know the research is very clear now. The perception of loneliness, again, let me define that. There's a difference between being alone and feeling lonely, but the perception of feeling lonely over long periods of time can have a physiological impact, adversely so. So we want to make sure we're building an intimacy in our conversations because that's actually a therapeutic tool to addressing the feeling of loneliness. I'm going to be humble for a minute. When we feel that intimacy with others in some form, it helps us feel attractive on some level, even if it's intellectual attraction, if it's emotional attraction, physical attraction, we need to have that in our life in some form. Dare I say, we want to feel loved. That's at the core of our existence. We want to feel valued in some way. We also want to have that hedonistic experience in a way. That's that feeling of pleasure, receiving and giving in the now. And then I will underscore that intimacy is really key for our neurologic and neuropsychiatric status, which I'll elaborate briefly in a moment too. So again, I think as Dr. Petrosian highlighted, the power of perspective, which I'll highlight later, is really key. So the psychological elements of intimacy are really important because it'll have a ripple effect. Having psychological security, comfort, and safety are at the foundation of intimacy. And then we know that those will have a physiological benefit as well. So we'll look at mind-body connection as it relates to the topic of intimacy. So with that, let me introduce this model for a moment. When we think of the biopsychosocial model, in essence, what we're saying is for a human's experience, for all of our experiences, there's a biological element to our experience, a psychological element, and then a sociocultural factor. Okay, so we have the biological, the psychological, and the sociocultural factor to health and wellness. When we talk about intimacy, there's a fourth really tier that is absolutely crucial to think about. That when we think about identity formation, that's influenced by our intimate relationships with others. To what extent we're feeling connected to somebody? To what extent are we feeling rejected from somebody? To what extent do we feel safe and secure with who we are when we're with somebody? And as many of us can appreciate here in the audience today is our identity may seem to change. Our identity may be a response to a situation, if you will, a medical one at that. And we'll talk about that briefly through the next set of slides. But let me deepen our understanding of this model by pointing this out. When we think about people with Parkinson's and we think about intimacy and how the biological, the psychological, and the social cultural factors can impact our sense of intimacy, we want to think about each one of those spheres. First, let's think about the neurochemical changes in Parkinson's. We have dopaminergic changes. As our previous speakers have said, many of them, it's not just dopamine, serotonergic pathways, acetylcholine relevant factor too. All these elements will impact our level of one, physical health, psychological health, which has a direct impact on intimacy. We also know medication effects can have a direct impact on our sexual experience, sometimes diminishing our ability to have sexual experiences, sometimes making us hypersexual as well. There are other medical factors we have to keep in mind. It's not just about Parkinson's. We can also have cardiovascular issues. Could be related to Parkinson's, could be independent. As Dr. Tagliati pointed out, there's an element of having diabetes for some, or in this case, insulin resistance that have a direct impact on our overall level of engagement, our fatigue, our stamina. Pain being a sensory experience. If we're having a lot of pain, it's hard to feel really intimate. When we look at cognitive changes, which has been discussed quite a bit today, that can impact our ability to engage in intimate interactions. And I mentioned this briefly. This could be a topic, every one of these in and of itself, but I do want to highlight our family culture, our nuclear family. When we were brought up, was it modeled for us? Did we see or exhibit or share intimacy in the family setting, emotionally, psychologically, intellectually? Did we see a sense of gender differences? Do we have race and ethnicity factors that are definitely relevant in how we experience or are willing to express intimacy? Our relationships, how healthy are they? Are they toxic? Are they therapeutic? Are they safe? With spouse, family, friends, and our care partners. Life stressors, huge as well, level of dependence. As we increasingly rely on others, we may feel less secure, which can have an impact on intimacy. Similarly, economic burdens, our ability to access healthcare and good treatment can have a direct impact on our intimate relationships. And of course, depression, anxiety, apathy can have a direct impact on our experience and even desire to be intimate. Apathy, again, is a symptom of depression, but apathy can be independent of symptoms of depression too, due to dopaminergic changes among other neurochemical changes that may impact our ability to feel alive and feel engaged. Psychosis, sleep disturbance are another couple set of symptoms that may be impacting relationships in their intimate exchange. That sense of identity and insecurity, if you will, and the sense of resilience, to what extent do we feel resilient or less resilient, can impact our sense of intimacy. So this is just context. So as we think about intimate relationships, we want to think about biological factors, psychological factors, and even our cultural backgrounds and how that may impact our ability to communicate and express intimate desires and even act on intimate desires as well. So let's talk broadly. This is now just appreciating our similarities and our differences, because we're a broad audience today with an outstanding attendance, but we want to make sure that intimacy is unique to an individual and a couple and a family system. So with that, we want to be mindful that even though intimacy is relevant across the age spectrum, as it relates to, again, physical, emotional, and intellectual and spiritual, it may change over time. So I want to be mindful that it might be context specific there. Some people are partnered, some people are single, but we still long for and need intimacy in our lives. It just may manifest in different ways. The duration of our relationships, with or without PD, can have an impact on our ability to be intimate or not. Sexual orientation, sexual pattern, sexual preference. Are we regularly sexually active? Is it once in a while? Are we really abstinent at this point in time? And I'll elaborate on this one, but PD specific factors are symptoms as it relates to disease duration, which we know is heterogeneous. It's not always applicable everywhere, but there are a lot of commonalities, and medication effects. So for time, I just want to go through these briefly here. So when we think of people with Parkinson's now, what is the experience of people with Parkinson's as it relates to intimacy? Not uncommonly, as a neuropsychologist, do I hear this come up, and I make intimacy a part of my conversations when I'm engaging in treatment. And that is the element for some, it's reduced desire. And they can't explain it, it just is. And sometimes it's biological, but sometimes it's a secondary impact. Fatigue or depression or medications create a reduction in desire. One thing that's, again, a very important topic is when we were introducing dopaminergic agents, dopamine agonists, and then you'll hear this term impulse control disorders. I'd be remiss if I didn't highlight it here, but for a subset of individuals, again, this is not ubiquitous, this is not for everyone, but for a subset of individuals, they maybe become hypersexual. They long for it more, they engage in it intellectually, they need it physically, and sometimes it's due to a pharmacological impact, an adverse impact due to dopaminergic agonists. So it can happen for a select group of individuals. And then now, beyond just intimacy, sexual dysfunction can be there. Men may struggle with getting or keeping erections or reaching orgasm, and women may experience dryness, pain, or having difficulty reaching orgasm as well. These are not uncommon symptoms for people with Parkinson's. Slowness of movement, tremor, rigidity, all can impact our ability to feel intimate, the desire to be intimate as well. And this is a topic too, back to communication. As Dr. Pedrosa was pointing out, communication styles can change. And sometimes it's about the affective changes. I see this and hear this commonly in my interactions with patients and their loved ones, is sometimes the emotional exchange is diminished. It's hard to interpret the emotional responses because maybe a flat affect may be there, or maybe the sense of humor is a little bit different than it once was, or sometimes there can be certainly cognitive changes that can occur that interfere with the affective relationships, the emotional experience, and the emotional exchange. Just putting these into a different format, these are also key. So drawing your attention to the left side of the screen, self-esteem can be hindered or take a big impact or hit when we start to have these symptoms that interfere with factors that are really important to us, including our relationships. Body image, we're an aesthetic society. So when we think about our body changes for men and women alike, it can definitely have an impact on our desire to be intimate, or even if we have the desire, but the security of feeling like we can be intimate. And role changes is big as well. Once we were very active in our shared experience and our defined roles in our relationships, sometimes those roles change. So to some extent, we were once, we're now more of a care partner than we feel like a spouse, and how that can impact our relationship with others. Communication difficulties, as mentioned, the inability to read nonverbal cues. There's a term called pragmatic communication, which is the understanding and interpretation of some elements of communication beyond the word exchange. And this was talked about too, the neuropsychiatric or even psychological side of distractibility, the executive function that changes, the memory that may change, the depression, anxiety that may interfere with our ability to be intimate. So let's talk too, just briefly, Challenges for the care partners, and let's change that differently. Challenges for our partners in life and how that may be relevant to our understanding of intimacy and the bi-directional relationship between intimacy within relationships. One, there might be one's own experience of anxiety, fear, and depression that could be entering into the relationship. We don't talk about this as not enough as well. Grief and loss, that sense of loss that comes with losing what was once familiar. I hear it often when someone, gosh, my family member, my loved one, they're different, they're changed, and I don't know how to navigate that course. There's a sense of grief and loss that comes with that. So unpacking that and understanding what it means is really important as well. Feeling less emotionally connected, in part, that's related to taking on more responsibilities. That's because we're doing so much more about caring, trying to manage the finances, manage our sense of well-being that's beyond the relationship, and all that investment in elements outside of the relationship take its toll on emotional connectivity and also create a sense of fatigue, sense of burnout, sense of exhaustion, if you will, that may impact relationship factors. I mentioned the role change again, moving away from the spousal connection and feeling more as a care partner is not necessarily, let me phrase that way, is not uncommon for a lot of relationships. And again, similarly for the person with Parkinson's and understanding nonverbal communication, that can happen as well for care partners, which hard to pick up on the nonverbal cues that once were there. So circling back to one of the quotes that I really embrace, applicable to this particular topic as well, is often people with chronic illness and even care partners may become trapped and invalidated, not purely by the force of the disease, but by the power of our beliefs about it. That's a really powerful statement. Why? Because if we can manage our perspective, manage our attitude, and manage our psychological health, it can actually enhance our connection with our loved ones, enhance our sense of intimacy with our partners. So with that, let's move into some intervention, okay? How do we rekindle and even redefine intimacy in our relationship? One, those 4 spheres I want to highlight, and this is not easy, so hopefully we do have our peer system in support, and our peer support system, in addition to our healthcare providers that can help navigate this course too. Emotional intimacy, being open about, transparent with your feelings, fears, and thoughts, creating an interaction that is safe and without judgment, expressing curiosity about the other's interests and well-being. Dr. Pedrosian, you were put in that situation of how do we address the I statements? You know, in addition to managing, the you statements and turning them into I statement, if we can raise it to an intellectual level and say, you know, hey, I'm curious about, I wonder if, can we talk about, that's a safe zone, rather than say, you do this, or when you do that, this happens. It's this pause to say, I own my feelings, I's, yes, and 2, I'm curious and I wonder, can we talk about our safe zones? That intellectual intimacy, sharing ideas, opinions, life perspectives, now in a mutual way that's non-judgmental, but sharing that space and feeling valued from our intellectual contribution. Spiritual intimacy, let me really define that for a moment. It's sharing our innermost kind of beliefs, our sense of purpose, our sense of connection with ourself, with others, nature, our existential beliefs. What is driving our sense of meaning and purpose now? That may involve spiritual beliefs relevant to religion, but it also can be very independent of that, just what drives our sense of meaning and purpose in life. And physical intimacy, really key points here. It's more than just the sexual contact. It's really about, can we touch a shoulder when we go by? Can we rest our hand on another? Can we hold hands? Dare I say, embrace the holding of hands for a prolonged moment. Exchange a hug. Have a lingering embrace. Cuddle, if you will, if you're sitting on the couch or laying in bed when next to each other. And then, of course, the kissing intimacy on the forehead, on the cheek, more intimately, sexual exchanges as well. But redefining what we think about physical intimacy is also important. We move away from the touch. If we can bring touch back into the experience in some form, that can be very powerful in feeling alive and feeling connected. Conversations, not easy. Because why? They're embarrassing, they're awkward, fear of upsetting the other individual. So what do? We call it the ostrich method of communication. We just don't talk about it. We avoid it. We sit next to each other, we're present, but we just don't talk about it. What I want to highlight though here is we can create a culture of communication at any point in time with our family members, with our loved ones. We're not stuck in the past with saying, well, it's too late. We're 45 years into our marriage. We're 15 years into our marriage. We're 5 years into our marriage. It's way past changing our culture. No, develop that culture, create a culture of conversation that involves intimacy, curiosity, and loving communication. We can do that even today, even now, setting that tone. So a couple more points, and then we'll open up to some Q&A, but these are key. How do we deepen emotional intimacy? Why I highlight this is because out of the intellectual, out of the spiritual, and out of the physical intimacy, emotional intimacy is the gateway. When we create the emotional intimacy, that is the most intellectually, spiritually, and physical gratifying way of experiencing each other. Create a space to talk about intimacy. The research is clear. The number one most crucial factor in improving physical intimacy and emotional intimacy is talking about it, communicating about it. Be patient, be kind, be loving in our interaction with each other. I love this quote by David Steiner-Rost. If we can bring gratitude into the moment, that creates a safer space and a more, hopefully, pleasant space for all involved. David Steiner-Rost says, you can't be grateful for every moment, but you can be grateful in every moment. Powerful statement, because we have gratitude, we have things in our life for which we can be grateful. Can we bring those even into the now? Be compassionate, be matter of fact. Let's not be ambiguous. When we're talking about intimacy, be very clear, be very communicative. Tough to do, but make ourselves feel a little vulnerable or create the space to be vulnerable. Create a sense of trust. Importantly, we need that non-judgment, which is not hard, which is not easy in our society today because we have opinions about everything. But if we can create a sense of non-judgmental communication, that's going to be powerful. Create a sense of shared, pleasurable times together, not just focusing on the responsibilities, appointment stressors. Create a pleasant moment. Take a nature moment. Even, gosh, Patrick, I loved your exercise. Even if we took a moment and stretched together, if we took a moment and engaged in physical movement together, side by side even, that can create a connection with one another. And I don't think we bring humor into our lives enough. Fortunately, we have a lot of technology to guide us. Bring a little levity in, try, manufacture a humorous moment. And again, take care of our emotional needs. Take a break from the frustrations, the anger, the disappointments. Bring in adaptive coping behaviors. So, concluding remarks. 1, you're not alone. You're not alone. 2, intimacy is more than physical. Intimacy is about emotional, intellectual, and spiritual connectivity in addition to physical. Gaps in intimate encounters or the absence of intimacy can be influenced by biological, psychological, and sociocultural factors. So we're trying to enhance our intimacy in our relationships. Let's put it in a context that helps us better understand it. Create a culture of intimacy. Talk about it. As we know as psychologists, to manage anxiety, to manage fear, to manage things that are uncomfortable, exposure therapy. The more we talk about intimacy in a way that's meaningful, the easier it is to do over time. And then tap into available resources. I think as Dr. Pedrosian and other, Dr. Sumsky said this as well. If we can tap into our resources, physicians, yes, mental health professionals, psychologists, licensed clinical social workers, occupational and physical therapists, and our community support. We have medical providers that are trained in addressing intimacy. Occupational therapists, one, of course, our mental health professionals as well. Key to tap into those resources. So I'll conclude with these points, then I'll get to my takeaways of 3. 1, let me highlight. Janine Roth is a great writer. She talks about this. Intimacy is not something that just happens between 2 people. It's a way of being alive. At every moment, we're choosing either to reveal ourselves or to protect ourselves, to value ourselves or to diminish ourselves, to tell the truth or to hide, to dive into life or to avoid it. Intimacy is making the choice to be connected to rather than isolated from our deepest truth at that moment. Powerful words, not easy to apply, but a reminder of the power of intimacy and the choice we have to be intimate. So I know, gosh, Patrick, like many others, you gave us a task, 3 takeaways. Some of us just can't do 3, so I have 1 for good measure. But 1, be intentional, not just in talk, but in action. Create time to be together with an intimate frame of mind. Be patient in your presence, kind with your words, and grateful in the moment. Touch each other often in some form, touching the hand, touching the shoulder. Laugh, be playful, and for good measure, be creative. Try to bring some novelty into the relationship. Try to bring some creativity. Leave a post-it note thinking of you. It's right next to the coffee machine. Sure, I could say it, but can I put it there just to have a different expression of my affection? And with that, thank you all for your time. Again, I thank you for attending today, your attention as well, and certainly to our board. And to Patrick, Judy, Vivian, again, thank you for the opportunity. And thank you again for all the fellow panelists who presented today.
Thank you so much, Jeffrey. This was not only informative, but moving. As I was sitting here listening to you, I was, thinking of some of the couples I've known that maybe aren't in crisis, but are maybe struggling a bit in the communication and maybe the intimacy as well. And I was thinking, maybe I should ask Jeff what would be a good first thing to do. And I think watching this presentation would be with your partner would be incredibly useful. I found this really, really wonderful. So we've got a couple of questions here. This is a little bit of a term, but I think it's important. How does Viagra impact Parkinson's patients?
Yeah, it's a great question to ask. We'll look at sexual stimulants, and particularly want to look at pharmacological interventions. First and huge takeaway, talk to your medical provider, talk to your quarterback. You need to talk to your physician because broadly, some individuals have medical conditions that can be contraindicated. Okay, so can people take these stimulants? People with Parkinson's, yes, okay, but I would also really emphasize there are different interventions today that are out there. Some may be better suited for you than others. So yes, in this case, can be helpful for individuals with Parkinson's to use such sexual stimulants. The key is talk to your physicians to make sure it's not contraindicated with your other medications or your specific medical conditions.
What are some tips on creating a safe and trusting space for these conversations? Love that one.
Excellent question. I often say, first and foremost, get permission. So if we want a safe place for it, we say, look, I really want to talk to you about our own relationship intimacy. Is now a good time? Are we in a good space to do that for each other? So we create that. Then it's yes, no. So instead of, because otherwise we can jump in and force the conversation, but if it's not complementary to a dialogue and it's more of a monologue, it might be difficult. So first and foremost, create discussion by creating space for permission. Is this a good time? 2, okay, set time aside for it. In this case, you could say, hey, look, I know we've got a lot to do today. So, but look, can we squeeze this conversation? And we don't want to do that. So make sure we have enough time to say, I really want to sit and talk about this. And 2, at number 3, actually, I would say this, Patrick, to that great question is to say, look, disclose where you stand with it. I'm feeling very vulnerable when I'm talking about this, but it's very important to me to talk about this. So I want you just to listen at first, and then I'd love to hear your thoughts. So then you share your thoughts and your experience, and then you create the space for that response. So those are ways that you can initiate the conversation. And lastly, Patrick, one more quick disclaimer. If it's hard to do on your own, sometimes the mental health provider can be a great way to create that safe space. Is you bring in a licensed clinical social worker, a psychologist, even an occupational therapist that might say, look, we can bring that intervention into our relationship for a session or part of a session. So that could be helpful as well.
Is there some kind of exercise or opening conversation that can help someone that may have a family member? So this is not for the person with Parkinson's, this is for the family member or a close friend that pulls away from the person with Parkinson's.
Yes, definitely. I think the intervention itself is to, when we have that family member, is to understand what's going on in their life that's resulting in their pulling away. Because sometimes it's not just about that person. They might be taxed in all these other elements of life and they're feeling overwhelmed. So withdrawing, not just from one person, but maybe several may be going on. Their own depression, their anxiety, their own stress. So my first way, I guess my response would be, if one has a relationship with that family member or person who's pulling away, is to ask and just call it out there and say, look, I'm just curious, how have things been for you? This is what I'm noticing, and I could be wrong. I'm just an outside perspective, but I notice sometimes it's not uncommon to pull away from relationships. I'm seeing that. Is anything going on for you that you'd like to discuss? How can I be here for you? So that's kind of a gateway into the conversation, and you're letting the other person, in fact, it's a gift to them, is saying, I'm noticing their changes. Is there anything that we can do to discuss that together? Because I want you to know I'm here for you.
Well, Jeffrey, thank you so much. These were such practical tips for handling such a delicate but important issue in people's lives. So thank you so much for taking the time to put this together.
My pleasure. And thank you all.
Really appreciate it. Well, I'm seeing all these chats coming through. Yes, I'm trying to find questions and everybody's just saying, thank you for a wonderful presentation. Well, we had a great time organizing this. And this was something new for PCLA in terms of the format. And I'm just so happy the way it turned out. And once again, we're so glad that you joined us today. Our programs and support groups are all free to the community. PCLA increasingly relies on donations of individuals like you to continue our work. Please make your donation at pcla.org so we can see you here again next year. PCLA is a nonprofit 501(c)(3). All donations are tax deductible. Special thanks again to our presenters today, and a heartfelt thank you to our wonderful sponsors, Acadia and Medtronic, and to you who make events like this possible. From all of us at PCLA, thank you.